Thank you, everyone, and welcome back to the ACIP meeting on February 23rd. And we are going to go ahead and get started with the next session, which is RSV vaccines, pediatric and maternal. And we invite our workgroup ACIP chair, Dr. Sarah Long, of the RSV vaccines workgroup, to provide an introduction and overview of today's session.
Thank you. I'm privileged to share the workgroup deliberations. May I have the next slide, please? As you look at this tremendous list of experts, all of them participating very actively in our workgroup, I'm struck, having served on many national policy guideline and vaccine licensing committees, the extraordinary resources that the CDC brings to give us the best evidence, and of the experts who work at CDC and this work group in making very difficult and complex decisions with the best evidence that we could have. The process is remarkable, and these are some of the people that help us see what we need to know and help us make the decision. So my colleagues from the ACIP members, Pablo Sanchez, Camille Cotton on my right, and Oliver Brooks in California at the moment. The ex officio members, the consultants, the group that have been dealing with RSV in one form or another for many years. I want to shout out to Cody Meissner, who for the American Academy of Pediatrics lived through the decisions of the first passive immunization against RSV. And my wonderful CDC colleagues, the co-leads of our committee, Catherine Fleming-Dutra and Jefferson Jones. And next slide, please. The process is remarkable, and yet the decisions are all complex. Everyone else in every other work group realizes the complexity of the decisions, but RSV, I think, is even more complicated. You have seen the epidemiology and burden of RSV disease in infants. You have seen the seasonality in the United States. You have seen the outpatient emergency department visit, hospitalization, and deaths related to RSV annually in the United States, as well as the virology and immunology of the organism. And we have begun to show you the first immunization, a passive immunization, nirsevimab, which is a pre-fusion RSV antibody with neutralizing capacity that is potent and of long duration, long half-life. We have shown you previously the phase 3 study in infants born near term, and the 2B study of infants born prematurely, and the phase 2-3 safety and pharmacokinetic study in infants at high risk for RSV disease. Next slide, please. Our agenda today is broad and deep, and we have been given almost 2 hours to do this, so we very much look forward to all of your participation in helping us see the questions yet to be asked. First, we'll see the cost-effective analysis from the partners at the University of Michigan for nirsevimab, which will be called the CDC model. The cost-effective analysis by Ismael Ortega Sanchez from the CDC to compare CDC and the manufacturer model. Evidence to recommendations framework for nirsevimab, Dr. Jefferson Jones. Clinical considerations for the monoclonal antibody, Dr. Jefferson Jones. And safety and efficacy of RSV bivalent A and B pre-fusion maternal vaccine, switching between the 4th and 5th bullets from nirsevimab to an adult pregnant woman maternal vaccine presented by Pfizer, and the work group consideration by Dr. Catherine Fleming-Dutra. The first presentation, I turn back to you, Dr. Lee, to introduce Dr. Hutton. I want to just, I'm sorry, I meant to clarify at the end here, for everyone to realize that neither of these products has been approved by the FDA. The FDA has not completed the evaluation of either the monoclonal antibody or the maternal vaccine, and any recommendation that ACIP would make would follow licensure of the product. Thank you.
Thank you, Dr. Long. And we'll move on to the next presentation by Dr. David Hutton from the University of Michigan on cost-effectiveness analysis for nirsevimab.
Thank you. Good morning. I'm happy to share the results of our economic analysis of nirsevimab in pediatric populations. Next slide, please. I'd like to acknowledge our research team, which includes collaborators from the University of Michigan and CDC, many of whom have extensive RSV expertise. Let's go to the next slide. We have no conflicts to report. Next slide. Our overall goal was to evaluate the cost effectiveness of nirsevimab. We're examining outcomes of resource utilization, cases, costs, deaths, and quality-adjusted life years lost from RSV. In the end, we compare the incremental cost-effectiveness ratio of nirsevimab to no nirsevimab and explore scenario analyses to examine key areas of uncertainty related to these questions. Let's go to the next slide. In order to conduct this analysis, we're using a decision tree model. Our decision tree incorporates several parts. We're examining a U.S. pediatric population under the age of 7 months entering their first RSV season. In a secondary analysis, we examine high-risk infants in their second season. We're comparing nirsevimab to no nirsevimab, which I may refer to as natural history. We're looking at nirsevimab's impact on RSV over one season, but then use a lifetime analytic horizon to look at outcomes that might last beyond that year, like years lost due to deaths. Next slide. In order to conduct the analysis, we're using a decision tree model. Our decision tree incorporates several parts to it. The top of the diagram shows what happens with no prophylaxis. With no prophylaxis, individuals can become infected. Infection can lead to hospitalization, emergency department visits, outpatient visits, or none of the above. Children who are hospitalized can potentially die. At the bottom of the tree, you can see outcomes related to nirsevimab. Nirsevimab may involve several adverse events, and then individuals can experience the same RSV outcomes as seen above. However, the likelihood of those RSV outcomes is lower with nirsevimab. Using the decision tree, we can calculate numbers of events and cost, quality-adjusted life years, numbers needed to prophylax for these different outcomes, and cost per quality-adjusted life year gain. Because this is a decision tree model, it doesn't take into account reductions in RSV transmission. As such, the main results are not dependent on uptake of nirsevimab. We also don't take into account infections that are not medically attended. Next slide. Let's first focus on the epidemiology of RSV. This slide shows our estimation of RSV hospitalization incidence. These estimates come from the CDC New Vaccine Surveillance Network from the season starting in 2016 and ending in 2020. You can see rates are higher for younger age groups and then drop off for older children. In the base case, we assume nirsevimab only reduces lower respiratory tract infections. So we must make an assumption about how many of these visits are due to lower respiratory tract infections, and we're assuming that 100% of these hospitalizations are from lower respiratory tract infections based on a study by Renish et al. Next slide. In our model, mortality is linked to hospitalization. This slide shows information on incidence of emergency department visits and outpatient visits. The top section shows incidence of emergency visits per 100,000 children. Rates are higher for the youngest age groups, and they drop as children get older. These rates come from studies by Lively and Hall and Jackson. You can see in this table, we also make assumptions about the proportion of these ED and outpatient visits that are due to lower respiratory tract infections. These estimates also come from the study by Renish. Next slide. In our model, mortality is linked to hospitalization, and this slide shows our estimates of RSV mortality, given that someone is hospitalized. Next slide. Our model incorporates information in monthly time periods to track incidence of RSV along with the timing of nirsevimab administration, and we also track waning protection over time. This graph shows the seasonality of RSV each month throughout the year. Most of the infections are occurring November through April, and seasonality data here comes from the National Respiratory and Enteric Virus Surveillance System from 2015 through 2019. Next slide. This graph shows the curve of how we model efficacy, starting high and then dropping over time. The average efficacy in the first 5 months is equivalent to the efficacy observed in the trial. the efficacy in months 6 through 10 is lower efficacy, and then we assume efficacy drops to 0 after month 10. A majority of the high efficacy is in the first few months. Next slide. Here are the precise numbers for the efficacy assumptions. The initial efficacy in months 1 through 5 is 80%. That's on average based on the MELODY trial in the phase 2B recommended dose. For months 6 through 10, the base efficacy assumption is 25%, but we vary that from 0 to 50% in sensitivity analysis. Efficacy is assumed to be 0% in month 10 and after. Next slide. I want to review our assumptions about how nirsevimab is provided. We assume nirsevimab is given at birth for those born during the RSV season from October through March. And then for all other children born outside the RSV season, nirsevimab would be given at their regularly scheduled 2, 4, or 6-month visits, which would occur in October or November, depending on when the child was born. Next slide. Here we have RSV costs. We have disease-specific hospitalization costs of a little less than $11,500. ED costs are a bit over $550, and outpatient visits are a bit over $80. These estimates come from a systematic review by Bowser published in 2022. Next slide. Because we're conducting the analysis from a societal perspective, we also include productivity costs. We include days of productivity lost for caregivers if their child gets sick with a medically attended case of RSV. We also include productivity loss if a child dies. This is in addition to quality adjusted life years lost. Next slide. We also include the cost of the intervention. And in our base case, we assume a $300 nirsevimab cost per dose. We vary that in sensitivity analysis from $50 to $600. Next slide. We also include quality of life lost due to RSV. This table shows quality adjusted life years lost due to RSV, not only for the child, but from a caregiver. We have different levels of quality adjusted life years lost for outpatient visits, ED visits, and hospitalizations. The table is actually showing the quality of life lost in terms of quality adjusted life days lost, so that it would be more intuitive since RSV typically affects children in timescales of days. As an example, an outpatient visit would lead a child to lose 3.1 quality adjusted life days and also would cause a caregiver to lose 1.5 quality adjusted life days. Although this table shows numbers in quality adjusted life days, in the end, we convert them to quality adjusted life years by dividing the values by 365. There's a lot of uncertainty surrounding quality of life losses from RSV. The lower ranges are based on a study by Rayonier, and the upper bound is based on an unpublished survey conducted during the pandemic that asked for quality of life lost from outpatient and inpatient RSV events for children and their caregivers. Next slide. We also included inputs related to adverse events. These include systemic reactions, injection site reactions, and serious adverse events. We include the rates of those events, as well as the medical and productivity costs and quality adjusted life years losses associated with those adverse events. Next slide. In addition to our base case results, we also conducted many uncertainty analyses. We conducted one-way sensitivity analysis varying each parameter one at a time. We also ran some scenario analyses. In the first, we examined what if nirsevimab also reduced upper respiratory tract infections to the same extent that they reduced lower respiratory tract infections. Another scenario analysis we examined was the impact of changing the timing of nirsevimab administration. Finally, we also examined an additional scenario looking at high-risk children entering their second RSV season. Now let's look at results. Our results start with a base case where we look at a hypothetical cohort of 1,000 births, and we assume 100% uptake of nirsevimab. We're looking at the first RSV season and assuming $300 cost per dose, and that nirsevimab only reduces lower respiratory tract infections. Next slide. Here are some resulting health outcomes with natural history and with nirsevimab. The graph shows the number of events that would occur over one RSV season. The light blue bar shows upper respiratory tract infections, and the darker blue bar is lower respiratory tract infections. You can see the darker blue lower respiratory tract infections bars, they're reducing with nirsevimab, and the upper respiratory tract infection bars are not shrinking. Next slide. This graph shows the events averted with nirsevimab per 1,000 births. We show outpatient visits, ED visits, inpatient visits, ICU stays, inpatient days, and ICU days. Next slide. We can also look at the results in terms of number needed to prophylax to avoid one of these events. For example, 128 people would be needed to be prophylaxed to avoid one inpatient stay. Next slide. This next figure shows costs. It has a lot of information on it. Each different subsection here is a different cost category, and within that we show 2 bars for natural history and nirsevimab. The different colored bars represent different types of costs. The light blue bars represent medical costs, and the dark blue bars represent productivity costs. Here we see in the first light blue bar that nirsevimab has a little over $300,000 in intervention costs. That's the cost of nirsevimab and adverse events from nirsevimab. The intervention costs are higher for nirsevimab than for natural history. However, in the other cost categories related to RSV disease, such as outpatient, ED, inpatient, and deaths, the nirsevimab costs are lower. So nirsevimab saves costs associated with RSV disease. However, the healthcare and productivity cost savings from reduced RSV do not quite offset the cost of providing nirsevimab. So in the end, when we look at the total cost bars on the far right, nirsevimab is more expensive than natural history. Next slide. In this figure, we show the cost per event averted. For example, we see with nirsevimab, we're paying about $2,476 per outpatient visit averted, or $18,515 per inpatient visit averted. Next slide. Here are the quality adjusted life years lost for a population of 1,000 births. With nirsevimab, we lose 0.03 quality adjusted life years due to adverse events, but we would lose far fewer quality adjusted life years overall with nirsevimab as compared to natural history because of averted RSV outcomes and impacts to the children and their caregivers. Overall, natural history loses 4.73 quality adjusted life years, whereas the nirsevimab strategy only loses 3.32 quality adjusted life years. Next slide. So this table shows the overall cost effectiveness summary measures. Overall, the nirsevimab strategy is $144,926 more expensive than no prophylaxis. But we would save 1.42 quality adjusted life years with nirsevimab. So the overall incremental cost effectiveness ratio is $102,805 per quality adjusted life year gained. Next slide. Now I'd like to show our sensitivity analysis. Because this is a new product, we're uncertain about many things. This graph shows how the top 10 most influential parameter assumptions affect the cost effectiveness of nirsevimab. On the left side, you see the individual parameter names, and the colored bars in the middle show how each parameter can affect the incremental cost effectiveness ratio. Recall that the base case incremental cost effectiveness ratio was about $100,000 per quality adjusted life year gained. The light blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter was lower, and the dark blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter was higher. As you look at the top bar, you can see how nirsevimab cost can change the results. If the nirsevimab costs were lower at $50 per dose, providing nirsevimab would be cost saving. However, if nirsevimab's costs were higher at $600 per dose, then the incremental cost effectiveness ratio increases to $315,613 per quality adjusted life year gained. The next section below nirsevimab cost in the light gray subsection is parameters related to nirsevimab efficacy. If the nirsevimab efficacy is higher, then the incremental cost effectiveness ratio drops. The other parameters in that light gray section are related to the fraction of RSV infections that nirsevimab might impact. The section below that, in the lightest gray, includes parameters related to the quality adjusted life years lost from RSV. The dark blue portion of the bars suggests that children and their caregivers would be losing a lot of quality of life from RSV. If that's the case, nirsevimab looks more cost effective. Next slide. The first important parameter is cost. So here's a graph showing how the incremental cost effectiveness ratio varies as the cost of nirsevimab changes. The blue dot shows our initial assumption of $300 per dose. But if it were more expensive, then the incremental cost effectiveness ratio would rise. And if nirsevimab were cheaper, then the incremental cost effectiveness ratio would drop. Next slide. This next graph shows the impact if nirsevimab also were to reduce upper respiratory tract infections. If we assume that nirsevimab only affects lower respiratory tract infections, then we get the events averted in the dark blue bars. That's our base case. But in the base case, we're averting 57 outpatient visits. But if we assume that nirsevimab also reduces upper respiratory tract infections with the same effectiveness has been shown to reduce lower respiratory tract infections, then our infections averted would be shown in the light blue bars. In that case, nirsevimab would avert 108 outpatient visits, and similarly, if nirsevimab also reduces upper respiratory tract infections, we'd also avert more ED visits as well. Next slide. If nirsevimab also reduces upper respiratory tract infections, it substantially lowers the cost-effectiveness ratio. In this scenario, the incremental cost-effectiveness ratio would drop to $45,092 per quality-adjusted life year gained, again, if nirsevimab costs $300 per dose. Next slide. Now I'll review how changing the timing of administration of nirsevimab might affect its cost-effectiveness. Recall that in our base case, we assumed that it would be given to newborns in October through March. But in this analysis, we will also look at it being administered to newborns in October through February or October through April. Those born out of the season would still be given nirsevimab at the beginning of the season in October or November. We'll also vary the efficacy in months 6 through 10 from 0 to 50%. Next slide. Here we can see how the cost effectiveness of nirsevimab would change as we change the timing of newborn administration and as we change the efficacy in months 6 through 10. We can find the different colored bars here that the timing of administration does not have a huge impact on the overall incremental cost effectiveness ratio. Whether children born in March or April get nirsevimab at birth or in the fall does not make a huge difference in the incremental cost effectiveness ratio. There are trade-offs between providing nirsevimab at birth when the children are most vulnerable and providing nirsevimab in the fall when protection would be most likely to match the peak of the RSV season. These effects roughly cancel each other out, so the timing does not make a huge difference in terms of cost effectiveness. Next slide. One other scenario I'd like to show is one where we see if giving nirsevimab would lead to a reduction in palivizumab use being given to high-risk children. In the base case, we did not change palivizumab usage. But here on this slide, we show what the potential cost impact might be if clinicians chose to give nirsevimab instead of palivizumab to infants who are currently getting palivizumab. I have a few additional assumptions listed here about the current use of palivizumab. If nirsevimab replaces palivizumab, then the incremental cost effectiveness or the incremental cost of nirsevimab drops. It's not quite as increasingly expensive. We have essentially the same health outcomes. So now our incremental cost effectiveness ratio ends up being about $59,250 per quality adjusted life year gained. Next slide. Finally, I want to talk about higher risk children entering the second RSV season. In this scenario, we're assuming immunization in October for those under 19 months old. To define high risk, we will explore a range of increased incidence of RSV-associated hospitalization and mortality. We'll start with 1 times incidence, which means there's no increase in incidence. But then we'll also look at 2 times, 4 times, 6 times, and 10 times higher incidence for RSV-associated hospitalization and increases in mortality given hospitalization. We also look at a $600 cost, which is equivalent to 2 doses at $300, or a $1,000 total cost, which is 2 $500 doses. Next slide. This table shows cost-effectiveness results for nirsevimab in a second season. We have the increased risk of hospitalization and mortality rate along the left-hand side, and then we have 2 columns, one for a $600 total cost of nirsevimab and one for a $1,000 total cost of nirsevimab. Sorry, this figure shows these results here. The y-axis shows events averted, and each colored bar represents different risk levels. If there's no increased risk, we can look at the purple bars and see if there are not many events averted. But those are older children that have lower risks to start with. However, with a really high risk population, like 6 or 10 times risk of hospitalization and death, the events averted are much higher. Okay, now let's go to the next slide and see the table. Okay, so this table shows cost effectiveness results for nirsevimab in the second season. We have the increased risk of hospitalization and mortality rate along the left-hand side, and then we have the 2 columns, one for the $600 total cost of nirsevimab and one for the $1,000 total cost of nirsevimab. Nirsevimab given in the second season is very expensive if the population is not much higher risk. However, if this is a population with a much higher risk than the general population, maybe 6 or 10 times the base risk of hospitalization and death, then giving nirsevimab could potentially be a lot more cost-effective. That's the bottom of this table here. Next slide. I'd like to point out some limitations of our analysis. The model structure does not contain varying risk groups besides age. The analysis of the first season is done for all children regardless of risk. The model does not include dynamic transmission, and so nirsevimab is not reducing population transmission of RSV. Additionally, models like this are a function of the underlying parameter assumptions, and we have many uncertain inputs. We're uncertain what the actual nirsevimab cost will be for payers, and we don't have great information on quality of life with RSV, and we lack data on long-term efficacy. Next slide. In summary, the cost effectiveness of nirsevimab depends on many factors, particularly the cost per dose. It could cause the incremental cost effectiveness ratio to vary between being cost saving to over $300,000 per quality adjusted life year gained. The nirsevimab efficacy, particularly against upper respiratory tract infections, could cause the incremental cost effectiveness ratio to vary between roughly $75,000 and $150,000 per quality adjusted life year gained. And then finally, variations in the quality of life with RSV for both children and caregivers could cause the incremental cost effectiveness ratio to vary between $40,000 and $125,000 per quality adjusted life year gained. So under certain conditions, nirsevimab may be cost effective, but under other conditions, it might look less favorable. Next slide. So thank you, and I'm happy to answer any questions you might have.
Dr. Hutton, thank you for that excellent and very clear presentation. I am happy to open this presentation for questions. Ms. Bata.
Just a quick question related to the base case and your assumption of 100% uptake in the nirsevimab group. What's that based on? I'm just thinking of parents who are refusing vitamin K, refusing hepatitis B, so I don't know if that's the best assumption.
So that's a great question, and you're absolutely right that we probably won't have 100% uptake, and this is kind of theoretical. What if we had 100% uptake? Now, interestingly, if we had a lower uptake, the incremental cost effectiveness ratio would actually be exactly the same because we'd have lower costs of giving nirsevimab, but of course we'd have lower benefits in terms of reduced RSV. So this is a hypothetical with 100% uptake, but we would have exactly the same incremental cost effectiveness ratios if we had lower uptake parameters.
Dr. Paling? Oh, sorry, Ms. Bata, did you have another question? No? Okay, Dr. Paling.
Thank you for a very clear presentation and thinking of so many different scenarios because they all do come into play. I wanted to ask about the scenario that I had when my son was young. So at 3 months of age in January, got his first RSV infection, was a happy wheezer, and got his first ear infection. Is that included in your upper respiratory infection category, and would have that been captured? Thank you.
So we are assuming that nirsevimab is, in our base case, is only affecting lower respiratory tract infections, and so we would not simulate any impact on upper respiratory tract infections. Now, and we don't simulate anything that's not medically attended to. So we're not capturing any outcomes that would not be medically attended in our base case. In the scenario analysis with upper respiratory tract infections, that would capture upper respiratory tract infection impacts.
Thank you. Dr. Long, did you have a question? No. Dr. Chen.
In building the model, I guess I wanted to understand about, I think that nirsevimab is weight-based dosing, and there's the 50 milligram versus the 100 milligram based on 5 kilograms or more or less. Was there an assumption that you were using for the dose of $300 cost? Was there an assumption that that was a fixed cost no matter which weight-based dose the child received, or was there an assumption that all children were greater than 5 kilograms, therefore receiving 100 milligrams? What was the thinking behind that in building the model?
That's a good question, and that is something we don't take weight into account in this model. We just use a fixed $300 cost per dose, and so you could think of that as a weighted average maybe of the cost based on a weighted population of various weights of the babies.
And was the 300 just grabbed out of the air, or was that informed in any way to try to estimate that?
So that's a great question. I mean, when we do these analyses, we do have to pick some numbers. We thought that was a reasonable number to start with. As it turns out, I think the manufacturer has a different cost in mind, which is why we did the sensitivity analysis on the cost. Now, of course, what the manufacturer sets as the price may not be the price that payers pay as well too. So I think it's important to also look at that sensitivity analysis based on the price as well to get a sense of what you think the cost effectiveness might be.
Dr. Jones?
Our understanding, while nothing is final, is that it'll be an identical price for the lower dose and higher dose.
Thank you. You know, are there any questions about the analysis? Any additional questions? Not seeing any hands. Oh, great, thank you. Dr. Young?
Yes, I wondered if there was any consideration for when nirsevimab would be recommended for even breastfed babies. Breastfed babies who are exclusively human milk fed have a significant protection against RSV already. So would the recommendation just be blind from birth on? Are any considerations made for that? And you would give both upper respiratory tract and lower respiratory tract protection from human milk feeding.
So we did not take that into account. So we're just assuming that, you know, the children are getting this directly at birth, and we don't have kind of differential recommendations for breastfed versus non-breastfed children in this analysis.
Thank you. One last question, well, maybe more of a comment than a question, but you know, the sensitivity analyses were incredibly helpful. In terms of, I was looking at two slides, one clarification question on slide 34, which is your reduction in palivizumab use. I just wanted to confirm that those ICERs, the incremental cost effectiveness ratios, include not only the palivizumab population, palivizumab eligible, but also those who might be eligible for nirsevimab. Is that correct?
So yeah, that's a great question. This is showing the results for the entire 1,000 child population. 1.6% of whom are high risk. 75% of those would be taking palivizumab. So it's only 1.2% or so of the population would actually be getting palivizumab. The other almost 99% would be the remaining population who are not palivizumab eligible. And so these numbers for that entire population, most of whom are not palivizumab eligible. Does that answer your question?
It does, and it then also implies that if we were to take a look in the population who was eligible, the incremental cost effectiveness ratios would look even more substantial for that small
yes,
subset of the population.
It's you know, we think it's better in terms of efficacy and lower cost than palivizumab. So so in that particular population of palivizumab eligible high risk children, it would be more cost effective.
Thank you. And then my second sort of comment, I guess, is related to slide 37. And this sensitivity analysis was particularly helpful because I'm going to actually go back to the RSV work group and ask, you know, do we have a sense of what the hospitalization and mortality risk would be for certain high-risk populations, and how to define those populations? I just don't know if we have those types of data available, but clearly it has a huge impact, and I'm assuming that question will come up clinically because we get it already now for palivizumab.
We'll discuss that at another time, but we are looking at data, and again, the resources of the individuals. There are data on some of these potential high-risk conditions for a second year.
Thank you. And then one last question, perhaps for Dr. Long, and then Dr. Romero. But my last question is, do you anticipate also providing information on non-medically attended RSV infections? And part of the reason I ask is because I actually appreciate that this model didn't include that, because I think it provides a reasonable assumption, and we don't know what the efficacy would look like. But it does seem like not everybody comes to the doctor. So to Dr. Paling's point about somebody who's at home who might not come in, but it still has a substantial impact on those families.
Comment on that?
Sure. I mean, for our initial model, in general, we have been leaning towards making conservative assumptions until real world or other data is available where we could make those adjustments.
Thank you so much. And Dr. Sanchez.
I think that, you know, first of all, I think that's a very difficult number to capture if they never seek any medical care. But I think ultimately nirsevimab may very well impact that, because it may not be a complete protection, but what we may see is just a milder infection that may hopefully just allow these infants to stay home. But I do think that there may be an impact on overall infection with nirsevimab that goes beyond just lower respiratory tract infection.
Thank you. And Dr. Romero, did you want to add anything?
Just a question, comment. So the model presumes that for those children born out of season, that you would administer this monoclonal at the 4 or 6 month visit. Now, that's somewhat different than what we do today for high-risk individuals, where we begin to give the prophylactic prior to or at the beginning of an RSV season, so October, for example. In theory, that schedule would place some of these children at 2 months of risk for infection. And, would that be something that would actually be recommended? Would you say, look, we have this monoclonal antibody that prevents RSV, but you can't get it for 2 months while the RSV season is playing? So that may add another visit to administration. I simply throw that out.
Thank you. I mean, that would be a wonderful sort of edit or clarification or sensitivity analysis to consider, because it would add costs with an additional visit. So appreciate that perspective. And I apologize, I like cost effectiveness.
May I just comment to this?
Oh, yes.
And Dr. Jones and Dr. Fleming-Dutra, if I don't have this right, but I think the strategy would be to use the 2, 4, and 6 month visits for those children who were not born in season, and to get that at the visit just before the onset of season. So I don't think that the strategy would leave individuals at risk. Is that correct, Dr. Jones?
We will be have more data, and perhaps this discussion will be easier after the future presentations for this session.
Thank you. And, we'll move on and we'll bring that back to a later discussion. We'll move on to Dr. Ismael Ortega-Sanchez, who will be presenting on the overall review of the cost effectiveness analyses. Thank you.
Good morning. My name is Ismael Ortega-Sanchez. I'm the senior economist at the NCIRD CDC. Today, I will attempt to compare and summarize key elements and findings of 2 economic models on the use of nirsevimab for the prevention of lower respiratory tract infection caused by respiratory syncytial virus among infants in the United States. These studies have been presented and discussed in extension in the Maternal and Pediatric Working Group. Next slide, please. The first study has been conducted by Sanofi and its collaborators. Sanofi manufactures nirsevimab. The second study is the one that you have just seen by Dr. Hutton from the University of Michigan. And for full disclosure, I want to say that I have been part of the team that conducted the CDC model. All authors, no conflict of interest in a part of the CDC model. Next slide, please. As in all economic evaluation of health interventions, the 2 models start with addressing the policy question. Specifically for the nirsevimab, this is the policy questions or questions under consideration, and you may be familiar with these ones. Most comparisons in this presentation will be focused on the how and on how the 2 models address the first question, and we'll touch in a few places the second question, the second part of the question. Next slide, please. To consider the economics of the policy question is to consider simultaneously the health benefits and costs of nirsevimab immunization. Namely, is the use of nirsevimab against RSV LRTI in all infants less than 8 months entering their first RSV season or born during season cost effective? To address this question, the 2 models use the same comparator, the standard of care in infants in first season and high-risk children entering the second season. And by standard of care, we assume palivizumab only for infants eligible as per the American Association of Pediatrics recommendation, and no immunization for all other preterms and terms infants. We'll be focusing on analyzing then the cost effectiveness of giving nirsevimab to infants in the first season and high-risk children in the second season. Next slide, please. Depending on the policy question, key elements of this economic model will be defined, namely the modeling approach, the inputs for RSV disease burden, nirsevimab efficacy, and costs, and some influential assumptions that will be compared across the two models. In the following slides, I'm going to be starting this comparison. Next slide, please. In general, the two models follow similar designs. Namely, the two models use a static analytical decision-making approach, relying on probabilistic or deterministic sensitivity analysis to manage the various data uncertainties, model hypothetical populations of infants less than 8 months and high-risk children 8 to 19 months, and use reasonable timeframes, analytical horizons, and discount rates. They also accounted for loss of income associated with temporary productivity loss in caregivers or premature death in patients. Next slide, please. Once the models were set, they were fed by different types of inputs data. And here we can see the clinical, epidemiological, economic, and quality of life data, including the nirsevimab clinical characteristics. Across models, the sources, specific values, and assumptions of these parameters had some overlaps, but there were marked differences as well. For your consultation, the full report with these input data and assumptions from these models have been made available could be made available for the ACIP members. Back to this slide. In the boxes are listed and check marked the standard outcomes estimated and reported by the two models, in particular the ratios of incremental cost per QualiSafe and the number needed to immunize to prevent a health outcome. With that in hand, this slide, please. This could be considered as an office summary report card. And this is the data that has been presented to a summary of the data that has been presented to the working group. And for your information, among the reported outcomes in this summary card, we have the base case estimates for all infants less than 7 months in season 1 to be about $70,000 per QualiSafe when the nirsevimab costs approximately $500 per dose. The QualiS findings is supported with simulations and sensitivity analysis, we can see on the right side of this graph. When simultaneously varying the input variables in the model, most of the simulations, including those on the base case, came back being somewhat costly, but also with some gains in QualiS, as represented by the orange dots within the first quadrant. Next slide, please. As you have seen this data recently by the presentation of Dr. Hutton, among the reported outcomes, we have the base case estimates for all infants less than 7 months in season 1 to be around $102,000 per QualiSafe when nirsevimab costs approximately $300 per dose. The first takeaway from these two slides will be that both models agree that nirsevimab will be costly, but it will also prevent LRTI, hospitalizations, and save QualiS among infants and caregivers. Next slide, please. Yet, what explains the different discrepancy and the difference in Sanofi model's main outcomes when compared with those of the CDC model? And here you can see them side by side. And pay attention that even though the CDC model assumes a lower nirsevimab cost per dose, its cost per QualiSafe are higher than those of Sanofi. The same observation could be done for the cost per hospitalization averted, as shown close to the bottom of this table. Next slide, please. To understand the discrepancies in these estimates, in this and the following two slides, we will try to identify the main sources driving these differences. Here, the CDC model provides sensitivity analysis of key variables used in this model. This is the figure that is a little bit reordered than the one that was presented by David Hutton, only in the way how the variables are ranked from top to bottom, from the most influential ones. Yeah, as you may know, the purpose of tornado figures is to identify the rank the most influential input variables from the top to the bottom. In these figures, base is described with a solid vertical black line, and the size of the horizontal bars describes the magnitude and direction of the influence of each input when varied to the higher and lower bounds of the variable. Note that nirsevimab cost comes to the top of the most influential variable, as was explained by Dr. Hutton, followed by nirsevimab efficacy in hospitalized infants, quality of life with RSV LRTI diagnosis, and epidemiological variables. Next slide, please. In a similar fashion, Sanofi reported one-way sensitivity analysis for key variables. Ranked at the top are epidemiological variables like the risk of RSV, followed by treatment cost and efficacy, and as can be observed, the price of nirsevimab does not appear. Next slide, please. Aside from the cost per dose, the common influential variables identified in the review of this analysis, and remember that we have access not only to the presentations, but also to the technical reports that were submitted to the ACIP, we could identify 4 categories of variables that could be influential in the difference of these estimates. One group of variables is the RSV hospitalization rates. The second is the unitary medical cost of RSV hospitalization. The third one is the RSV season and intervention period, and the initial efficacy and waning. Although this slide provides some of the information here, I will be visiting some of these topics in the next slide. Please, next slide. If we look closer to the key differences, we could see marked differences in the rates of hospitalization and unitary medical costs of hospitalization or outpatient. As shown in this table, the annual risk of hospitalization and medical costs as input data points used in the Sanofi model are on the high end, while those used in CDC model are on the lower one. We may consider that the higher these input values are, the lower the ICERs will be, or what is equivalent, the more cost-effective a nirsevimab recommendation would be. Next slide, please. Particularly influential is the rate of hospitalization, and it's also the input data with sizable uncertainty. Sanofi uses the age and term-specific hospitalization rates among McLaurin, published in 2016, and while the CDC model uses the RSV-associated hospitalization rates among children aged less than 2 years from the laboratory confirmed RSV-associated hospitalization, laboratory confirmed rates from the new vaccine surveillance network. And this slide shows the difference between the 2 input values used in the model. The next slide, please. Likewise, data sources of RSV season, namely the percent of RSV cases by month and how interventions were modeled, have some marked difference, as can be seen in this slide. Although both intervention seasons begin in October, Sanofi intervention, the purple rectangle shade, finishes in February, while in the CDC model, it runs until the end of March, the light blue square shade. There are a number of details that you can see in terms of what specifically happens in the intervention of Sanofi versus the CDC model. Some of them already been discussed, and as we can see, there are some elements that can be taken into account in terms of what explains the difference in the estimates. Next slide, please. This table shows the initial efficacy at the starting point of the potential impact of nirsevimab. Both models showing similar, if not equal, input values for this variable. It helps to understand, though, that what comes next with the duration of protection, which will be analyzed in the next slide. Next slide, please. Although it's important how well nirsevimab effectiveness starts in an RSV season, it's much more important how it performs during the whole season. The 2 models rely on available duration of protection data for nirsevimab trials that cover approximately 5 to 6 months. However, after this initial period, the residual protection is based on assumptions. Both the Sanofi and CDC model assume no residual protection after 10 months, although the Sanofi follows a linear decay, while the CDC uses a sigmoid to fit the initial efficacy and the presumptive residual after 6 months to drop later to 0% at month 10th. Next slide, please. In this slide, using the CDC model, but with the assumptions that were used by Sanofi, we tried to come up with some estimates or a summary of the estimates that have already been presented by Dr. Kutton. What if the base case and scenario results using the CDC model as assumed in Sanofi model are, when we compare, for example, the base case, if the cost of nirsevimab were equal to $500 per dose in a 1-year time frame, the cost per quality will be about 150% higher when we are using the input data from CDC and the model approach as well. If the intervention period would be October to February, as has been seen also, the cost per quality would be about approximately 6% higher. And if lower bound medical costs for hospitalization are used, the cost per quality will be around 10% higher. On the other hand, if prevention of all medically attended RSV visits, including LRTI and URTI, will be included, the cost per quality will reduce up to 50% approximately. Similarly, if the nirsevimab price per dose will be about $200 per dose, the cost per quality will drop to less than 1/3 relative to the base case cost per quality. This is using the CDC analysis, the CDC model. Next slide, please. Among the limitations that have not been discussed in the previous slides, the factors not considered that may result in overestimating the ICER, which means that that may be underestimating the cost effectiveness, are the following. In the base case, both models assume no protection against upper respiratory tract infection, no protection against asymptomatic unattended lower respiratory tract infection. Also, neither model includes RSV-related costs incurred after discharge from an RSV-associated hospitalization or emergency department visits. Namely, the productivity loss incurred by caregivers after discharge are not taken into account. Both models assume no indirect effects of nirsevimab immunization. It means that the approach of the model is focused only on the direct impact of the use of nirsevimab, and no indirect protection against RSV transmission is included. Next slide, please. As a conclusion, the difference in key inputs among Sanofi and UC and CDC model explain differences in the results. These are the variables that are the most significant ones, with nirsevimab cost per dose as the one that is very highlighted here, and the inputs used in the Sanofi model being on the extreme high, on the high end, and the CDC model on the lower end. In general, we can say that nirsevimab will significantly reduce the RSV disease burden in infants. Data from the clinical trial support the impact estimated on disease reduction. However, the economic value of using nirsevimab in infants could be costly or cost-effective, and reasonable price and duration of protection combined with careful design of seasonal interventions will determine the cost-effectiveness value of routine prophylaxis among infants less than 7 months of age entering the first RSV season and those born during the RSV season. Next slide, please. Finally, to end this presentation, let me acknowledge my colleagues, my collaborators that helped me to put together this presentation, and also to the Maternal Pediatric RSV Working Group members. Thank you.
Thank you so much, Dr. Ortega-Sanchez. This presentation is now open for questions. Dr. Talbot, thank you.
This is fascinating, and so I have lots of questions for the work group in this setting. It sounds like to me the idea would be that all children would be given this, and hence would postpone their first RSV infection until they were a little bit older. The infections that we currently see in 2- and 3-year-olds are typically reinfections, so they appear mild. Do we have any data that if we postpone infections to their first infection to their second or year of life, will it still be mild?
So that's an interesting point that actually we have some experience from the COVID experience, because with the pandemic, we saw no RSV during the height of the pandemic. And then we were actually seeing children being hospitalized at 2 to 3 years. Anecdotally, I will say that they seem to have some more significant disease. However, by CDC criteria, they have not seen that, and maybe Jefferson can comment. So the current thinking is that there is no increased or worse disease in the toddler age range, but Jefferson may comment.
Real quick, but not better. No worse, but not better. Is that what you're telling me?
Well, not that it's not worse.
Okay.
Yeah.
So a couple points. First, if the first infection was postponed until a child was later, it is presumed that their risk for severe disease or hospitalization would be considerably lower. The second is that the manufacturer has told us verbally, but we haven't been able to review the data, that for their randomized controlled trial data for breakthrough infections, or those that received nirsevimab but were still infected, had similar level of antibodies against non-PreF proteins as those who were infected that received placebo. And they've interpreted that as there is still a robust response to the virus that could provide similar protection. Again, we haven't reviewed that data, but that is what we've been told.
And just so I'm clear, you said it's presumed that it would be less severe, but we don't have data to support that.
So in the context of when we look at risk of severe disease by age, it's considerably less, and I'll review that data in the next 1 or 2 presentations, the risk of RSV hospitalization by age. Now that is in the context of people being exposed over time, but I think not everyone is infected. Like it's by the second year of life, nearly everyone's infected. The first year of life ranges around 2/3 or so.
Dr. Paling?
Building on Dr. Talbot's question, the perception of clinicians this year is that we're seeing a lot more 2- and 3-year-olds who've never had an infection before, and it's more prevalent. And so I guess one of the questions is, through the NVSN or some of our surveillance, can we capture what's going on this year to provide some more insights into what's going on? Because the masking and staying at home, there's a lot more kids who've had a primary infection this year.
I think that what we're seeing this year is complex. Some of the children are older and complicated and missed a year of booster RSV. So it's not all primary infection that we're seeing in 2- and 3-year-olds. The second thing is we don't have evidence that this monoclonal antibody will prevent infection. So I don't think we're putting off infection. I think we're making their first infection less likely to be symptomatic. And then finally, from old work, you probably participated in this work also, Dr. Romero yourself, but also Dr. Hall. If your primary infection proves serologically by being naive and then getting RSV, in your second year of life, you're much less likely to have lower respiratory tract infection. So it's both age and how much RSV you've seen in the past.
And just to say that, like, airways get bigger the older you get, and there's a huge difference between like a 3-month-old and a 2-year-old.
So just one more question about that. Do we have second-year data so that we see that the immune responses post-antibody infusion are not aberrant and are actually helpful?
Comment on what the company is doing.
So in October, what was presented was rates of RSV, MALRTI, and hospitalization for the second season among those that were, I believe, in the phase 3 trial, and they didn't see increased rates among those that received nirsevimab versus placebo. NSVN data will be able to look at these age groups. We've begun to look at it, including like the median age for different seasons, but of course, again, it is different. Those who received nirsevimab versus those who were infected during the pandemic.
Thank you. And we're going to move on to the next session, which is the evidence to recommendations framework for nirsevimab. I'm sure, oh, Dr. Paling, was your card up? Okay, feel free, Dr. Paling.
All right, so Dr. Ortega-Sanchez, thank you for this presentation and explaining the differences in the models. One of the concepts I was trying to figure out was for this product to be cost savings or cost neutral under these different assumptions. I'm guesstimating it's about $150 a dose for the CDC model, and could you help me with the Sanofi model where that would be? Thank you.
Yeah, that is a very important question. And so far, the sensitivity analysis that has been provided to ACIP by Sanofi doesn't include a scenario where there would be a cost saving. Although you can see, for example, if we go back to the report card, I think it's a slide number, one of the slide, the report number, the slide in the, that the sum of the simulations come below the this is the one exactly. As you can see that there are the sum of the simulations that come below, so therefore there's a potential for a cost of there's a potential for a lower cost of per dose to be cost saving. Yeah, even at in this model, all the variables were varied, but I'm not sure if the vaccine cost was varied at the same time. So the potential for having a cost saving scenario using a lower cost per dose is very likely. I hope this answers your question.
Thank you. Yes, she's nodding. We're going to move on to the next set of presentations, which will be presented by Dr. Jefferson Jones on the evidence to recommendations framework for nirsevimab, followed by clinical considerations for nirsevimab, and then we'll open it up for discussion.
All right, good morning. Today I will review the evidence to recommendations, or ETR, framework for nirsevimab. At times I will refer to nirsevimab as an immunization because it is a form of passive immunization. Active immunity results from infection or vaccination, which triggers an immune response. Passive immunity is when a person receives antibodies from an external source. One example is antibodies transferred from a mother to baby through the placenta or breast milk. Another example is direct administration of antibodies, and these include intravenous immune globulin or monoclonal antibodies such as nirsevimab. Today, we will review ETR for 2 policy questions. The first is, should 1 dose of nirsevimab be recommended, A, at birth for all infants born during October to March, and B, when entering the RSV season and less than 8 months of age for all infants born during April through September. And the next presentation will discuss the recommended timing of administration and age in more detail. The second policy question is, should nirsevimab be recommended for children less than 20 months of age entering their 2nd RSV season who remain at increased risk of severe disease? Our PICO question for the first policy question is, the population is all infants born during April to September who are less than 8 months of age when entering their first RSV season, and infants born during October to March. The intervention is nirsevimab, and the comparison is no nirsevimab. We looked at several outcomes that will be discussed in more detail during the benefits and harms domain of ETR. We will be reviewing the following domains and questions. The first ETR domain is the public health problem with the question, is RSV-associated disease among infants less than 8 months of age entering the first RSV season and infants born during the RSV season of public health importance? So referring briefly for the question by Dr. Romero previously, I think this data in particular is of importance. So prior to the COVID-19 pandemic, RSV transmission had followed a consistent seasonal pattern. So shown in gray and black, the 2016 to 2020 seasons consistently peaked during December to February. However, the COVID-19 pandemic interrupted seasonal circulation of RSV and many other respiratory viruses, Following over a year of limited RSV circulation, the U.S. experienced an interseasonal RSV wave, shown here in blue, that peaked in early August 2021, and that peak continued throughout the fall into late December, as shown in yellow on the left. As shown in yellow on the right, in summer 2022, limited regional interseasonal transmission occurred, largely in the South and South-Central United States. As shown in green, RSV peaked in October to November 2022 and is decreasing, suggesting that RSV circulation might be transitioning to typical winter seasonality. We estimate that each year among U.S. children aged less than 5 years, RSV is associated with 100 to 300 deaths, approximately 58 to 80,000 hospitalizations, 520,000 emergency department visits, and 1.5 million outpatient visits. Pre-pandemic RSV seasonality is well defined with limited geographic variability in most of the United States. RSV is the most common cause of hospitalization in U.S. infants. The highest hospitalization rates are in the first months of life, and risk declines with increasing age in infancy and during early childhood. Prematurity and other chronic diseases increase the risk of RSV-associated hospitalization, but most hospitalizations are in healthy term infants. The work group felt that RSV-associated disease among infants is of public health importance. The next domain is benefits and harms, which asks, do the desirable effects outweigh the undesirable effects? The work group used both published data and additional data requested by the work group. The critical outcomes identified by the work group are the top 4 in the table: medically attended RSV, lower respiratory tract infection, or LRTI, RSV LRTI with hospitalization, RSV LRTI with ICU admission, and death due to RSV. Important outcomes are all-cause medically attended LRTI, all-cause LRTI-associated hospitalization, and serious adverse events, or SAEs. We evaluated all outcomes using pooled estimates from the Phase 3 and Phase 2b randomized controlled trials that were presented at the October ACIP meeting using the recommended dose. Aggregate data for additional outcomes listed were provided by the manufacturer to the work group. This differs from the full data submission to the FDA as part of the biologics license application used for regulatory purposes. Of note, no deaths were identified in these trials, and therefore this outcome could not be evaluated. Pooled estimates combining the Phase 2b and Phase 3 trials using recommended dose are shown in addition to the concerns in certainty of assessment per grade methods. The estimated efficacy for medically attended RSV LRTI was 79%, for hospitalization was 80.6%, and for ICU admission was 90%. The Phase 3 trial was conducted partially during the COVID-19 pandemic, which temporarily led to lower than expected incidence of RSV. This concern applied to all outcomes shown for indirectness, but was deemed not serious. For protection against ICU admission, few ICU admissions were reported, leading to wide confidence intervals. We rated this a serious concern because of fragility or imprecision of the estimates of efficacy for ICU admissions. No deaths were recorded, and this outcome could not be evaluated. The estimated efficacy against all-cause medically attended LRTI was 34.8%, and against all-cause LRTI hospitalization was 44.9%. The risk ratio comparing SAEs in infants receiving nirsevimab versus receiving placebo was 0.73. Because too few participants were included in the trials to detect rare events like anaphylaxis, which is typical for trials, we rated this as a serious concern for imprecision. In summary, there is a high certainty that nirsevimab is effective in preventing medically attended RSV and RSV hospitalization, in addition to preventing all-cause medically attended LRTI and LRTI hospitalization. There is moderate certainty that nirsevimab is effective in protecting against RSV LRTI with ICU admission, and that SAEs are not more common in infants receiving nirsevimab than placebo. And we were not able to evaluate death. Overall, we rated the evidence as moderate certainty because of concerns in the precision of protection against ICU admission and ability to detect rare SAEs. The work group felt that the anticipated effect for the main desirable outcomes was large, but some members felt the effects were moderate. The work group felt that the anticipated effect for undesirable outcomes was minimal to small. And the work group felt that the balance between the desirable effects relative to the undesirable effects favors nirsevimab more than no intervention. The next domain is values, which asks, does the target population feel that the desirable effects are large relative to the undesirable effects, and is there important uncertainty in these values? In a survey conducted by the University of Iowa of 523 people who were actively pregnant or pregnant within the last 12 months, as shown in the red color, about 1/3 of respondents thought their baby definitely or probably would get an RSV infection within 1 year after being born. And 70% of respondents, represented in blue, said they definitely or probably would get an RSV antibody injection for their baby if safe and effective, licensed by FDA, and recommended by CDC. 63% of respondents said they were more worried, shown in light blue, or equally worried, shown in dark blue, about their baby experiencing side effects from an RSV antibody injection versus symptoms if sick with RSV. 38% of respondents believed that their baby would have no symptoms or mild symptoms if they got sick with RSV, and 24% expressed uncertainty about the disease severity or treatability if their baby got sick with RSV. Despite being unsure of perceiving RSV risk to be low, respondents were worried their baby would need to be hospitalized if they got sick with RSV, with a mean response of 4 out of 5, with 5 being most worried. The work group felt that the target population probably feels that the desirable effects are large relative to the undesirable effects. However, the work group varied in whether they felt there was important uncertainty about or variability in how much people value the main outcomes. The next domain is acceptability with key stakeholders. In a survey by the Alliance for Patient Access and National Coalition for Infant Health of 175 providers using YouGov to poll U.S. physicians, over 85% of respondents agreed that parents need more information about RSV, that they already include RSV education as part of routine care, that immunization could help prevent RSV, and that immunization policy should ensure all children get access. The American Academy of Pediatrics, or AAP, has stated that the development of a safe and effective RSV immunization is a priority. In 2021, the National Foundation for Infectious Disease held a roundtable which agreed on the importance of rapid adoption and deployment of evidence-based RSV prevention. This roundtable included the National Association of County and City Health Officials. The work group felt that immunization with nirsevimab is acceptable to key stakeholders. The next domain is whether the intervention is feasible. Nirsevimab is administered as an intramuscular injection using pre-filled, single-use syringes available in 2 different doses for infants born during or entering the first RSV season. 50 milligrams or 0.5 milliliters for infants weighing less than 5 kilograms, or 100 milligrams or 1 milliliter for infants weighing 5 kilograms or more. For high-risk infants and children entering the second RSV season, the dosing is 200 milligrams, or 2 injections each with 100 milligrams. Only 1 dose of nirsevimab is recommended per RSV season. It is stored at refrigerator temperatures and may be kept at room temperature when protected from light for a maximum of 8 hours. Nirsevimab would be the first passive immunization product to be independently included in the CDC immunization schedule. Certain immunoglobulin products are already included, but are in conjunction with vaccines. For example, hepatitis B immune globulin and the hepatitis B vaccination. One reason for this is that the proposed indication is for all infants, and widespread use of nirsevimab would result in population-level impact. It is unknown at this time if nirsevimab will be included in the Vaccines for Children program. FDA has indicated they will likely classify nirsevimab as a drug. Some related workgroup considerations include that certain types of healthcare workers, particularly medical assistants, can administer vaccines but might not be able to administer a monoclonal antibody under current rules, which may require modification to enable administration of nirsevimab. Adverse events would be reported to the FDA Adverse Event Reporting System rather than the Vaccine Adverse Event Reporting System, or VAERS. Many providers are more familiar with VAERS, and the methodologies to analyze these systems differ. Billing and administration codes for nirsevimab have not been finalized and differ for vaccines versus drugs. Some state immunization information systems might not be able to include products that are considered drugs and not vaccines. The workgroup felt that nirsevimab is probably feasible to implement. However, some members said this was dependent on inclusion in VFC, and others said they didn't know or had concerns until more information on VFC was available. The next domain is resource use. Our primary source of data was the cost-effectiveness analyses that were previously presented. As a brief summary, in the base case with nirsevimab for the CDC model at a cost of $300 per infant, the incremental cost-effectiveness ratio was just over $100,000 per quality-adjusted life year, and at $500 per infant, it was a little under $245,000 per quality-adjusted life year. And you can refer to the full presentation for details. The workgroup was concerned about the potential cost of nirsevimab, and two polls were taken. At a cost of $300 per infant, the workgroup felt probably yes, with a minority stating yes, that use of nirsevimab would be a reasonable and efficient allocation of resources. At a cost of $500 per infant, approximately half of workgroup members said probably yes, while the remainder said no, probably no, or don't know if use of nirsevimab would be a reasonable and efficient allocation of resources. The next domain is the impact of nirsevimab on equity. As previously mentioned, the inclusion of nirsevimab in the VFC program is undetermined. If not included in VFC, state Medicaid, Medicaid expansion, or children's health insurance programs, and private insurance would likely cover nirsevimab. Underinsured and uninsured, or those who don't have Medicaid or Medicaid expansion, would likely have reduced access without a VFC option. Multiple studies have shown increased rates of RSV hospitalization among children who are American Indian and Alaska Native compared with the general population. Shown is one recent study from the RSV surveillance in Native American children or adults, or SUNA study, highlighted are seasonal incidents per 1,000 children among 4 American Indian and Alaska Native communities. Rates in infants were 19 to 112 hospitalizations per 1,000 infants. These rates are frequently 4 to 10 times the rate in the general population. This is thought to be due to social determinants of health, such as increased rates of poverty and crowding. The literature comparing rates of severe disease among non-Hispanic white, non-Hispanic black, and Hispanic children have shown mixed results. National studies of death certificates have found higher rates among non-Hispanic black compared with non-Hispanic white children. Hospitalization rates using NVSN surveillance data have shown mixed results. Several NVSN studies have shown no significant differences by race or ethnicity. Other studies have shown differences, but even when they have, the relative risk of hospitalization for non-Hispanic black and Hispanic children compared with non-Hispanic white children has been mildly increased. For example, a relative risk of 1.2 to 2.2, and has differed by age group. The work group varied in their opinion on nirsevimab's impact on equity. A large concern was uncertainty about inclusion in VFC. These were the workgroup interpretations for the ETR domains previously shown. The workgroup felt that the desirable consequences probably or clearly outweigh the undesirable consequences in most settings. And the workgroup recommended the intervention. I will now review ETR for the second indication. The PICO question was population, children aged less than 20 months who are increased risk of severe disease with RSV and who are entering their second RSV season. Their intervention was nirsevimab of 200 milligrams, and the comparison was no nirsevimab, and the same outcomes were used as the first indication. For public health problem, MVSN incidence of RSV-associated hospitalization for the years 2016 to 2020 are displayed. The incidence is lower in children aged 12 to 23 months compared with children aged 0 to 5 months and 6 to 11 months. To further illustrate these differences, this figure displays the incidence rate ratios using MVSN data. The hospitalization incidence rate ratio for infants aged 0 to 2 months versus 12 to 23 months was 6.1. For infants aged 3 to 5 months versus 12 to 23 months was 3.4. And for infants aged 6 to 11 months versus 12 to 23 months, the rate ratio was 1.9. The manufacturers proposed that children with the displayed risk groups, and potentially others, might warrant nirsevimab when entering their second RSV season. The Medley study, a pharmacokinetics and safety study, included palivizumab-eligible children with hemodynamically significant congenital heart disease and chronic lung disease for the second season, but not other conditions. Palivizumab is the only product currently licensed for prevention of RSV-associated disease in the United States. The American Academy of Pediatrics has identified groups of children at risk of severe disease from RSV during their second RSV season for the purposes of recommending palivizumab. Palivizumab is recommended for children with chronic lung disease if they require medical support within 6 months of the start of the second RSV season. And palivizumab can be considered for children that are profoundly immunocompromised or have cystic fibrosis if there are manifestations of severe lung disease. After reviewing available evidence, the workgroup felt that the same children currently eligible for palivizumab when entering their second RSV season, per the AAP recommendations, could be considered high risk for nirsevimab administration when entering their second RSV season. These groups are, again, children with chronic lung disease, if they require medical support during the 6 months period before the start of the second RSV season, children who are profoundly immunocompromised, and children with cystic fibrosis with manifestations of severe disease. Now, these are draft considerations, and other conditions are under review. For today, for all the ETR domains, the workgroup opinions are under the assumption that high risk refers to children eligible for palivizumab in their second season, as displayed in the previous slide. For benefits and harms, the Medley study, as it is known, included congenital heart disease and chronic lung disease cohorts that for season 1 had a 2-to-1 randomization of nirsevimab to palivizumab. For the second season, shown on the right, the nirsevimab group continued to receive nirsevimab, and the palivizumab group was randomized 1-to-1 for nirsevimab or a second season of palivizumab. Based on these data, we were only able to evaluate 2 outcomes: medically attended RSV LRTI and serious adverse events. Medley was a safety and pharmacokinetics, or PK study. It did not evaluate efficacy, and efficacy data for children entering their second RSV season is not available. The PK data from the trials in infants in their first RSV season were analyzed using modeling. An area under the curve was derived using individual estimates as a measure of exposure to nirsevimab, and then correlated it to efficacy for prevention of the first episode of medically attended RSV-LRTI in infants less than 12 months of age from the phase 2b, phase 3 medley trials. So based on these data, an area under the curve PK threshold of 12.8 day milligrams per milliliter was established. As a surrogate of efficacy, a predetermined threshold was that 80% of medley participants needed to be above that area of the area under the curve PK criteria, and 95.8% of infants receiving 200 milligrams of nirsevimab for their second RSV season were above that area under the curve criteria. So the work group had concerns, rated very serious, for the evidence for protection against medically attended RSV-LRTI because of indirectness with pharmacokinetics being used as a surrogate outcome, and that the area under the curve, PK threshold, was determined in the first season, and the indication is for the second RSV season. Finally, the population was limited to children with congenital heart disease and chronic lung disease, while other conditions are being considered as proposed indications for nirsevimab dose for children entering their second RSV season. For safety, adverse events are displayed in the first column. The group, so in the first column, it's the group that received palivizumab in both seasons, and no SAEs were reported. In the groups that received nirsevimab in the second season, for the last two columns, approximately 9 to 10% experienced an SAE. None of these SAEs were deemed by trial investigators to be related to the product, and no deaths were reported. The relative risk of having an SAE among those that received nirsevimab in their second RSV season compared with those that received palivizumab in their second RSV season was 8.4, but with a wide confidence interval. Serious concerns about indirectness were raised because the comparison group was palivizumab recipients rather than placebo. Additionally, there were serious concerns about imprecision because of the small number of participants in the trial. Combined, there was very low certainty in the evidence. In summary, nirsevimab might be effective in preventing medically attended RSV-LRTI, but with low certainty. Serious adverse events may not be more common in recipients of nirsevimab compared with children receiving no nirsevimab, but there is very low certainty. No data were available for other outcomes. Overall, the evidence rating was very low certainty. The work group felt the desirable anticipated effects were moderate. The work group felt that undesirable anticipated effects were minimal. However, some work group members felt they didn't know or that the undesirable anticipated effects were small to moderate. For palivizumab eligible children, the work group felt that the desirable effects outweigh the undesirable effects and favors nirsevimab. No additional data was available for values or acceptability specific to high-risk populations. The work group felt that the target population feels that the desirable effects are probably large relative to the undesirable effects, and that there is probably not important uncertainty or variability. For palivizumab eligible children, the work group felt that nirsevimab is acceptable, or probably acceptable, to key stakeholders. One additional consideration for feasibility is that an additional visit to provider might be needed for administration of nirsevimab prior to beginning of the second RSV season, either at a specialist clinic or the primary care provider. The work group felt that it was probably feasible to implement nirsevimab to palivizumab eligible children less than 20 months of age entering their second RSV season. For resource use, at $600 per child, the work group felt it was probably a reasonable and efficient allocation of resources. However, at $1,000 per child, the work group was split if it probably was or was not a reasonable and efficient allocation of resources. For equity, equity issues differ by chronic condition among infants and young children. Non-Hispanic Black populations, for example, experience higher rates of preterm birth than non-Hispanic white populations. For children with cystic fibrosis, the majority are from non-Hispanic white populations. Hispanic populations may have a higher prevalence of Down syndrome than non-Hispanic white populations. And Hispanic and non-Hispanic American Indian and Alaska Native populations may have higher prevalence of neuromuscular disorders than non-Hispanic white populations. There was no consensus on the impact of equity. Many members felt it would have no impact among palivizumab-eligible children, but several felt it could increase or reduce equity, or didn't know, with the primary concern being not knowing if this will be included in VFC. This is a summary of the workgroup judgments for the second RSV season indication. After reviewing the totality of the data presented today and acknowledging uncertainties around aspects of the data, the workgroup felt that the desirable consequences probably outweigh the undesirable consequences. And the workgroup proposed to ACIP to recommend the intervention for palivizumab-eligible children as defined by the American Academy of Pediatric Guidance. However, additional conditions will be reviewed. In summary, the workgroup recommends nirsevimab for all infants born during October to March at birth, and for all infants born during April to September who are less than 8 months of age when entering their first RSV season. However, many members expressed concerns about feasibility and equity, particularly because inclusion in VFC is unknown. Some workgroup members expressed concern that at higher prices, nirsevimab may not be reasonable and efficient allocation of resources. The workgroup would like more time to consider which infants and children would be sufficiently high risk to warrant nirsevimab in their second RSV season. There are limited efficacy and safety data available at this time in this population. And there are little data to measure the risk of severe disease in the second RSV season by chronic condition. At this time, the workgroup recommends nirsevimab for those who are eligible for palivizumab in their second RSV season per AAP guidance. And because nirsevimab is assumed to cost less than palivizumab and be of non-inferior efficacy, this was assumed to be cost-effective. The workgroup will continue to evaluate other conditions. So if licensed by FDA, the two questions we will ask ACIP to vote on are, 1, should 1 dose of nirsevimab be recommended for all infants born during October to March at birth, and for all infants born during April through September, less than 8 months of age, entering their first RSV season? And 2, should 1 dose of nirsevimab be recommended for children less than 20 months of age entering their second RSV season who are eligible for palivizumab in their second RSV season? The second question may have other conditions added. So our questions for the committee: do ACIP members have sufficient information to vote on these policy questions? And how do ACIP members feel about the inclusion of other populations for the second RSV season? This is a small number of the team that has put a lot of time and effort into preparing for this, and thank you to them.
Thank you.
Thanks. Should be,
Yeah,
as discussed.
I know it's a lot, but I actually feel like it'll be helpful for everybody to hear the clinical considerations component, and then we can come back for questions, and then we still have a couple more presentations. Thank you, everyone, for your patience, and I'll just ask really briefly, are there any quick clarification questions on the ETR? Because I think we need to have the bigger discussion. Okay, why don't you go ahead?
And relative to the prior presentation, this one will be relatively shorter. So,
Thank you for being so thorough about the ETR. We appreciate it.
So these are draft interim clinical considerations for nirsevimab. The goals of the work group were to develop recommendations that would provide simple, uniform recommendations that apply to most U.S. healthcare providers, yet also provide flexibility for specific situations. So for the first indication for infants born during or entering their first RSV season, so some important considerations for the work group when developing recommendations were that nirsevimab efficacy against medically attended RSV LRTI and hospitalization in the randomized control trials was assessed through 150 days after administration, and the efficacy beyond 150 days is unknown. Only one dose of nirsevimab is recommended per season, even if given early in the season. So if the nirsevimab dose is given too early before the season, for example, May or June, during the peak of the RSV season, the infant could be beyond 150 days after the dose and have waning protection. Thus, nirsevimab administration should be timed to maximize protection during the RSV season when infants are most at risk of exposure to RSV. For infants born during October to March, just before the start of most RSV seasons and during the months with the highest RSV activity, the optimal timing of nirsevimab dosing is at birth. For infants born during April to September, in months typically with low RSV circulation, the ideal timing for nirsevimab dosing is just before or near the start of the RSV season. Typically, this is mid-October to early December. So the 150-day period after administration includes the months of peak RSV circulation, December to February, when the infant is most at risk of exposure to RSV. Therefore, for infants born during October to March, nirsevimab is recommended shortly after birth or as soon as possible afterwards. Administration in the hospital prior to discharge is recommended to ensure protection. If this is not possible, administration at the first visit to the primary care provider, ideally within 1 week of discharge, can be considered. But not all infants are taken to their provider in the first week after discharge. For infants born April to September, nirsevimab is recommended to be administered during October to November, such as during regularly scheduled 2, 4, or 6 month well-child visits. So during the COVID-19 pandemic, interseasonal RSV transmission has occurred. The work group has expressed it is important to allow for flexibility of timing in nirsevimab administration during periods of significant interseasonal RSV transmission. However, for the upcoming 2023 to 24 season, nirsevimab may not be available prior to October 2023. So as a brief reminder, the incidence of RSV-associated hospitalization is substantially higher during the first 2 months of life and decreases with each month of life, and this needs to be balanced. The recommended timing of administration previously presented should serve as a uniform recommendation. If increased RSV transmission is occurring locally in August or September, nirsevimab could be administered earlier than October if available. The National Respiratory and Enteric Virus Surveillance System, or NERVS data, could be used as one factor in decision-making. Census division level or HHS regional level data is recommended to be used, as some state-level data may not be representative. Specific to NERVS data, and not local hospital or other data sources, greater than 3% positivity of PCR tests for 2 consecutive weeks can indicate an increased rate of RSV detection. To determine if nirsevimab should be continued to be administered to newborns shortly after birth beyond March, local jurisdictions can alter administration schedules based on local transmission conditions with clear evidence of ongoing increased transmission. Again, the local data may be a best indicator, but we recommend establishing an evidence-based threshold. And NERVS data, again, at the census division level or HHS regional level, could be used as one factor in decision-making. For NERVS data, less than 5% positivity of PCR tests for 2 consecutive weeks can indicate decreasing transmission. Tropical climates, including Hawaii, Guam, and the U.S.-affiliated Pacific Islands, may have RSV seasonality that differs from the majority of the continental U.S. or is unpredictable. Providers in these areas are recommended to administer nirsevimab to newborns at birth year-round to maximize protection in the first 150 days of life, the age at which infants are at the highest risk of hospitalization with RSV. Some specific jurisdictions, such as Puerto Rico, are recommending nirsevimab during August to March. And providers can consult with local, state, or territorial health departments for recommendations. In Alaska, RSV seasonality is less predictable, and the duration of RSV activity is often longer than the national average. And similar to palivizumab guidance from the AAP, providers are recommended to use RSV laboratory surveillance data generated by the state of Alaska to assist in determining the appropriate timing of nirsevimab. And the Alaska Department of Health will continue to provide clinicians with updated Alaska-specific guidance. Infants residing in remote areas who travel long distances to receive well child care, for example, those who require air medical evacuation for severe disease, can be given nirsevimab outside the normal schedule if there is concern that the infant may not have access to nirsevimab at the recommended time. For the second RSV season indication, as stated in the previous presentation, the same groups that are currently eligible for palivizumab when entering their second RSV season per AAP recommendations are recommended for nirsevimab when entering their second RSV season. And these groups were previously presented, and again, other conditions are under review, and this recommendation may change. Nirsevimab is recommended to be given during October to November when children are normally entering the RSV season. Nirsevimab is not recommended to be used after the second RSV season. I'll now open it up for questions.
Thank you very much, Dr. Jones. And may I suggest we go back to the first policy question and we anchor the conversations around policy question 1 and then policy question 2. For the ACIP members, I would ask that you provide any thoughts around the discussion that's needed or any opportunities that you would like to see in terms of the evidence to recommendations framework in order to be able to move forward with a recommendation. If you see any opportunities for additional information that would influence your decision-making, that's what we'd like to focus on. So Dr. Paling.
All right, so thank you, Dr. Jones. You have presented a tremendous amount of information and very clearly. I do like your first policy question, and now I'm going to dive in to, I recognize the huge burden of RSV and how that impacts young children and the families. You've also clearly highlighted there's a fair amount of logistic challenges that we really need to be thinking carefully about. And so one is we've been talking about disparities and the worry that this will lead to worsening disparities. And the coverage for uninsured in children is a really big deal. The billing is a big deal. And who can administer is a big deal. The other thing is I want to point out that some insurances have a bundled payment for birth hospitalizations. That would result in not being paid for this expensive drug in birth hospitalization and further worsen disparities. And then my other challenge that I'm thinking about is adverse reporting. Because if I understand VAERS correctly, it is the CDC and FDA are working together. And that's that is the platform that we're usually reporting to. And so my question is, if this is going to move forward, is there ability to report to either the FDA or VAERS and have them crosstalk? Because I think that would make it a lot easier on the practicing clinician. And then my last concern that I forgot about was the immunization registry. This is a huge deal, and we know that you need to know what the child received. And so, thank you.
So I think we've got 3 questions. One on, just quickly review. I think we'll first talk about VFC and bundle payments, then adverse event reporting, and then immunization registry. So first, on bundle payments, so CDC is in discussion with multiple agencies, and as highlighted, there are many challenges, and we feel it's really important that we address them so that if nirsevimab is licensed, we have as smooth as possible a process going into the upcoming RSV season. We've heard that bundle payments are updated, so while they may not have initial reimbursement, if nirsevimab is recommended and widely used, that those bundle payments would be updated to reflect the increased costs from its use. For VFC, that was in a, for VFC, I'd like to pass it on to colleagues at Immunization Services Division.
Hi, I'm Sarah Meyer. I'm the Chief Medical Officer for the Immunization Services Division. I think I just first wanted to highlight, I believe what Dr. Jones has said is, ensuring equitable access is is the highest priority in reviewing some of this. We want to make sure that all children, if this is licensed and recommended, that all children have access. And certainly the VFC program has been very effective in helping to reduce disparities for childhood vaccines. But as Dr. Jones pointed out, there are a lot of complexities with this being characterized as a therapeutic and not vaccine. Many of them he highlighted in his talk. This is another example of where there are a few additional things to kind of work through, but those discussions are happening. As Dr. Jones also mentioned, we are working closely with other federal agencies, including CMS, to explore all options to make sure that we can achieve equitable access of this product if it should be approved and recommended. And I think we don't have an update at today's meeting about that, but as those discussions occur and as there are further updates, those will be shared with the work group and the committee as soon as possible.
And for, I think, the next, I imagine we may have follow-up, and I welcome any of my other CDC, other colleagues who'd like to, if they have additional comments on VFC or other.
Dr. Romero, did you want to make a comment?
I just want to add a little bit more to coverage. So our current analysis suggests, and this is based on census data, that approximately 5.7% of all children under the age of 3 are not covered by insurance, either private, Medicaid, or CHIP. So that's something to consider when considering whether it's Medicaid or VFC.
Thank you, Dr. Romero. Do you want to work on safety next?
So adverse reporting. So the FDA adverse reporting system, FAERS, does differ from VAERS. And I believe you're all quite familiar, and many providers are, with the VAERS system, which CDC is very familiar with. The FAERS system, I'm hoping we will be able to present more information on it at a future meeting. Our CDER colleagues, rather than CBER, have been informing us about that system. It's our understanding if an adverse event for nirsevimab should be reported to VAERS, it would be forwarded on to FAERS. And the how that system is analyzed and how ACIP members can be made aware of interim analyses, we hope to discuss that at a future meeting.
Okay, let's see. I have a long list. Ms. McNally. And I just want to be, I want us to have this robust discussion. I also am just acknowledging that we may not have lunch if we keep going. So we're just going to have to find the right balance. So please be brief.
All right, I have two questions. Dr. Jones, I'm the consumer representative. So my first question for you is, do you know if when the survey was issued that was used to inform the values domain, whether those participants were educated about the schedule at 2 months, 4 months, and 6 months?
The survey was very recent, December to January, recent, so 2022 to 2023. We have additional questions about whether they follow the schedule or not for their children, and I can pull those out if desired. 68% of respondents had previously heard of RSV.
Okay, so my second question is, for the benefit of parents, how is the CDC and the work group convinced that there is no negative impact to a child's health in receiving this monoclonal antibody at the same time as other vaccines?
So we have discussed co-administration at the work group. The industry has sponsored a white paper that they published. The general consensus of the work group was that there is a lack of data on this, but the theoretical risk of adding a passive immunization to regular childhood vaccines poses a low risk. And I'd like to ask if some of our laboratory colleagues, Dr. Coughlin or Dr. Thornburg, if they have anything to add on this.
Hi, this is Melissa Coughlin, the team lead for the human immune response. I don't really have anything to add. I think we don't have the data, but I agree that the theoretical risk that providing an antibody in conjunction with a vaccine for any adverse event is low.
Yeah, and this is Dr. Thornburg. I would agree with both Dr. Coughlin and Dr. Jones. I mean, I think our best bet is to look at palivizumab administration and look for safety signals. That's been used for a very long time in a smaller population. And thus far, we haven't observed any safety signals with palivizumab.
Thank you. So what I'm hearing is it would be helpful to have as much, direct or indirect data as possible to review at the next meeting. Ms. Bata.
Thank you, and thank you for this review. It's been, I appreciate all of the data that you've covered. One of the things that, as I was thinking about this as a birth dose, the good news is that many institutions already have infrastructure in place for the hepatitis B dose. So that might be a way for us to understand that process and how to expand it. I think the concerning news that I have, or the concerning piece of information, is that our birth dose coverage for hepatitis B is 76%. That was in 2016, and in 2018-19, it was almost just under 80%. So we're still missing a lot of vaccination of infants.
Yeah, I mean, the presented the survey data on acceptability. We don't have anything specific. We will be publishing at least that values survey, and there are questions about various preferences, including birth dose versus at the primary care provider. It's unknown how the effects of the recent RSV wave will have on parents' desire to receive RSV prevention versus hepatitis B, perhaps.
Thank you. Dr. Daly?
Yeah, so Dr. Lee, I'm struggling because I have about 10 detailed questions, but I recognize I may not be able to get to them all. But
what would be great is if you could go ahead through them, and then if we can ask the team to come back with some of the responses, but anything that you think would be really helpful for today, if you could prioritize that way, that'd be great.
Yeah, and I actually am not going to bring up those 10 right now just because I want to make, fair warning, but I want to make some overall observations. I think I want to take a step back and say this is incredible, and I know we've talked about this before, but this is transformative, and I think we should recognize this. As a practicing pediatrician over the last 25 years, I've admitted more children for RSV bronchiolitis with hypoxia than anything else I've admitted children for, by far. And so this is extraordinary. So that's point one. Point two is we can do this, okay? I guess, I mean, but by we, I mean practicing pediatricians and practicing family medicine physicians and hospitals. I mean, I think we can do this. But, and here's where we come to the but, we've spent 50 years building a system for coverage surveillance, safety surveillance, and immunization delivery. And that's been 50 years that we built that system that works pretty darn well. And I'm concerned that we will not use that system and everything in there, immunization information systems, vaccine safety surveillance, and frankly, just administration to then achieve disease prevention that we want to achieve. And then we're going to fall because of things that are really understandable, but really more bureaucratic. So, I mean, I have concern that we're going to miss a lot of opportunities for disease prevention because we're not going to use a system that we've built for the last 50 years. So I actually do have a question. What I would love to hear about is from the AAP representative, because I have concerns about feasibility. And so I wonder if our AAP representative, if that individual's on, could just comment about sort of what do we think about feasibility in practice settings in hospitals for administration of nirsevimab? Thank you.
And Dr. O'Leary, are you on for AAP today?
I am. Thank you, Dr. Lee, and thanks, Dr. Daly. And I had my hand up to comment on specifically that issue. And really to echo Dr. Paling's point, I mean, I think what it comes down to, and this is really not directed at CDC, I think we're all on the same page. My comments are more directed to FDA and HHS. I've had concerns from when I first heard about it that this product would be considered as a drug as opposed to a vaccine. Obviously it's technically not a vaccine, but it is a passive immunization and would be given in the same way that most other vaccines are given to children. And for all the concerns that Dr. Daly mentioned, not using this system that really works well is very problematic. If this is not covered under the VFC program, it's going to create all kinds of problems unless there's another federal mechanism that I'm not aware of. If it's left up to individual states, it's almost certainly going to lead to inequities of delivery of this product and worsen existing health disparities. It would also, from the feasibility standpoint, no one's really sure what would happen in this case in practices if it was classified as something other than a vaccine. It just that we don't have a precedent for that. And ultimately, if this product is licensed and recommended for all children, it should be available to all children without respect to ability to pay. And that's really the bottom line. And I don't really see a way other than including it in the VFC program that's going to happen, and that it would solve so many problems. But I understand this is a complex topic, and I'll stop there.
Thank you. And actually, just to continue to finish responding to some of the questions that were raised, I see Dr. Shimabukuro, would you like to speak about safety? And he disappeared. So next we'll move on to
Dr. Lay, I'm sorry, I was talking on mute.
There you are. Okay.
Apologies. So just to back up a couple steps here, and I guess start at the beginning on safety. So this nirsevimab is regulated by CDER. So this is a CDER product, and the safety monitoring system is the FDA Adverse Event Reporting System, or FAERS. There are processes in place for the two systems, VAERS and FAERS, to redirect reports that are sent to essentially the missent to the wrong system. So if we do get reports into VAERS, we will have a process to identify those and to redirect those to FAERS, similar to how FAERS redirects vaccine reports to VAERS. And I think a lot of the monitoring issues there may be related to coordinating with FDA to make sure that that we're aware of safety findings. We do plan to monitor nirsevimab in the vaccine safety data link. In fact, we're in the process of planning to do that right now. So CDC will be monitoring the safety of nirsevimab, and that will be similar to how we do monitoring for routine vaccines or other vaccines. And we are able to capture co-administration of other vaccines in the vaccine safety data link. It's challenging to monitor safety when you have multiple vaccines or multiple products being administered, but we will have the data to look at co-administration. We also have another program at CDC called the Clinical Immunization Safety Assessment Project, which will be able to do clinical case consultations for U.S. healthcare providers of complex adverse events associated with the product or when the product is given with other vaccines. So CISA will still be, that resource will still be available. And we are also in the process of developing the next generation VSafe. So there would be other CDC systems which we could use to monitor the safety of this product. So I just wanted to make those points. Thanks.
Excellent. Thank you, Dr. Shimabukuro. Dr. Romero?
Since we have Dr. Shimabukuro on the line, and I still am trying to learn the difference between these two systems, but how fast is the transmission of data from FAERS to VAERS? Is it rapid transfer of information? Are they equipped to react as quickly as? And I'm not saying they don't, but we have experience with VAERS. We know how quickly you identify signals and move on them. Will we be able to get that data? Will the members of the ACIP get that data to vote to see and quickly without lag?
Dr. Romero, I think we would have to have continued discussions with our CDER colleagues on the FAERS system. I'm aware of the FAERS system, but I'm not. I don't know the details and the intricacies like I know for VAERS. But certainly having those conversations and ensuring that safety data could be made available to CDC on a timely basis is something that would be important to us, and I understand to ACIP as well.
Thank you. I'm convinced after COVID-19 we can do anything. So thank you, Dr. Shimabukuro. Ms. Coyle.
Good afternoon. I just wanted to highlight some of the issues that we know that are existing with IIS. I know that question was mentioned. So I just want to say that we know that there's going to be challenges with implementing this using the routine systems. Not only will it be challenging from a clinical decision perspective, recognizing that your forecasting has to account for seasonality and locality as well as other considerations. But there are also even more significant issues in the background as to how the data would be sent to the IIS. So not to overcomplicate things, but there are uniform code sets that every electronic health record system, every IIS uses. And because this is not considered a vaccine from a code set perspective, it will be cumbersome and costly to modify the systems using the existing pathways that we have now. So that's cumbersome and costly for IIS and every EHR that's out there. So I also just want to recognize that we know our CDC and FDA colleagues out there are very aware of the issues, as are many of the other partners out there. And so I know that folks are really trying to work through some of these challenges, but in terms of operationalizing sort of that send and receive feature that we're so familiar with for all the other vaccines, this would not probably take effect when this product goes live. So thank you.
Thank you. To all our federal partners on the line, it would be really helpful. I mean, honestly, it just sounds like if we call it a vaccine, which is the purpose is a prevention, it resolves many of these issues. I realize it's not that simple, but it does feel like we shouldn't let perfect be the enemy of good. If the intent is that we want to make sure we are providing access and equitable access and timely access, some of these implementation issues may be a significant barrier to us doing this in a reasonable way. Dr. Cotton?
Thank you. I think we've learned a lot. I think we've learned a lot from the experience with Evusheld. And I would ask for standardization as far as the ACIP and what we consider, and if we're going to consider passive immunization, that we do it standardly rather than Yeah, case-based, or it's not clear to me why we're reviewing this, but we didn't review Evusheld. And then I think we've learned a lot from the Evusheld experience. That information is not logged into immunization databases. It's actually quite cumbersome, as we've heard. And so maybe we can look at some lessons learned from that experience and think about how to implement this. Thank you.
Thank you. We're clearly entering a new era. Now, I see Dr. Sanchez and Dr. Long, but I'm also going to ask if you wouldn't mind, in addition to your comments, commenting on policy question number 2, which is now up, to see if we can provide any guidance and help to our colleagues, although Dr. Long, you are in charge of that work group, so.
I'm surprised that none of the ACIP members have questioned cost and resource utilization. So when we asked the manufacturer how they would price this, when they presented the 500, we had assumed a lower cost and modeled the 300. I think the answer was verbatim by value afforded, which would allow a broad range of how you might price a drug. You know, this would be, for the birth cohort, this would be $1 billion cost of the immunization alone, and not even considering administration fee. And we learned just yesterday that VFC budget is $4 million or $5 million? 5 million? Billion, not million, billion, sorry, a little decimal, a few decimals. So it is extraordinary, and how states dish out their money is very different. So the possibility is that other very important things could be dropped or lost, or because it could not be afforded. So I think that it would be hard for the committee, the work group committee, to say that there is a recommendation regardless of cost. There was a sense that that at the cost of $200, $300, this would be a go, and there was considerable trepidation for anything more than that. And the second thing is, we felt that there really had to be a decision about VFC and how this was going to be provided for us to make as an ACIP any recommendation for the use of this product. At the time we make the recommendation, we must know that.
Thank you. And I assume that applies to both question 1 and question 2. We're going to go to Dr. Sanchez and Dr. Young.
Thank you, Jefferson. And really, I really want to thank CDC and ACIP for taking this on, because, and yes, it's not a vaccine. We cannot say that it's a vaccine. In the era of vaccine hesitancy, I am afraid that some parents will refuse this medication in the name, because they don't want to receive a vaccine. And we can do all the education about the vaccine, but it is not a vaccine. And I've been in that situation in the NICU where parents have refused vaccines, but they have accepted palivizumab. So it is not, the message needs to be clear and accurate. But I really want to thank ACIP for taking this on, because any of us who've had to deal with palivizumab and the issues surrounding palivizumab has become horrendous, not just at the AAP level, not at the industry level, but also even at the local level, where one hospital and one NICU has one recommendation and the NICU across town has another recommendation. So I really am very happy and really pleased, because I think that this is groundbreaking if it works and if it gets approved and if we have it. It is a disease that we want to definitely be able to prevent, whether by providing the medication to infants or by maternal immunization, as we will hear later. So I think all of these hurdles are real hurdles. We've had to deal with them on a constant basis with palivizumab, and we have dealt with them successfully. And I see that we can do it, and we have to, and it's a must. And I'm just really happy that this is moving forward. Thank you.
Thank you. We're going to go to Dr. Young and then Dr. Paling.
Yes, I wondered whether any consideration had been given to use nirsevimab the way palivizumab was originally requested, which was 35 weeks and below. And you would get a piece, well, they wouldn't be term, and it wouldn't be all of the babies, but it would be on the population for which RSV was the highest issue. And you get a chance to see its process now that it's only requiring one injection, as opposed to what we have. I'm a neonatologist as well, as opposed to what we were up against in terms of in the nursery and then in follow-up and getting parents to come back to look at that schema and what it would play out to, as opposed to trying to take on the whole population of term infants for a disease that they probably would not see until they're more than 7 months, especially if we tell them to breastfeed their babies.
Hi, this is Dr. Jones. Based on MVSN and other active surveillance systems, the vast majority estimates, 2/3, up to 80% of hospitalized infants for RSV are in term infants without any chronic conditions. So given that high burden, if we assume, we've talked a little bit about cost, but the work group had felt that it's important to prevent that burden in these term infants given that data. We haven't looked at anything by breastfeeding status, but presumed that the recommendations would be for the full population.
I'm going to actually ask that Dr. Paling, do you both have your cards up still? Or no? Okay. Dr. Paling, can we get to the last comment? Because we are fairly behind schedule. I literally mean we might not eat lunch. So I would like to get to Dr. Paling. And then if you have anything, you would like to comment on vote 2. Great.
All right, I'm going to comment on the policy question, and I'm going to say thank you to the work group. I did like keeping it very similar to what we have been doing for years, and I do see the possibility of improved equity with giving a single dose rather than monthly doses. My concern is insurance. Insurance can take a year before they pay for anything. And we are seeing that, I believe Dr. Lair pointed out, PCV 15 is not paid by several insurances, and this is commonly exceeded. And this continues to be a problem with the birth hospitalization, because I think it would be a year that would decrease equity. And so my concern is that lag time as well. Thank you.
So I just wanted to comment on the second policy question. I think that there's a lot of uncertainty about the risk involved in the second season. But I do think, and there are recommendations already for RSV prophylaxis among the, children who have PPD who recently are medically attended or who have medical treatment for it, as well as congenital heart disease and immunocompromised and cystic fibrosis. So I think that withdrawing those from a recommendation when it is already standard care and it's being given with palivizumab, would be very difficult. So I would favor what Jefferson has said, that maintaining the same recommendations for a second season that are being for those children who are already receiving palivizumab.
Thank you. I'm going to actually ask if there's additional comments, Dr. Jones, if you'd be willing to stay a little bit later, and we're going to ask our members to just provide any additional information they would like to see that you haven't already heard about. We do need to move on to the next session, which is Dr. Iona Munjal from Pfizer speaking about the safety and efficacy of RSV bivalent pre-fusion, I almost said preference, maternal vaccine.
Thank you so much. I'm just going to share my slides. Just confirming that you can see and hear me.
We can, thank you. Your slides are up.
Thank you so much. Great, thank you. Good morning, actually good afternoon now. And thank you to the ACIP for the opportunity to present today. My name is Iona Manjal, and I'm a Senior Director at Pfizer in Vaccine Research and Development. And it's my pleasure to present the data in our ongoing maternal vaccine program for our bivalent RSV prefusion F candidate. We believe that this is the first time a maternal vaccine for infant efficacy has been presented in this forum, which brings us great joy regarding the future of maternal vaccines. We're seeking the following indication: the prevention of lower respiratory tract disease and severe lower respiratory tract disease caused by RSV in infants from birth through 6 months of age by active immunization of pregnant individuals. The dose level is 120 micrograms without an adjuvant. Each dose contains 60 micrograms each of each prefusion protein antigen A and B in a 0.5 ml injection. The presentation is a lyophilized vial with a water for injection pre-filled syringe. The vaccine is to be stored at 2 to 8 degrees Celsius. The target of Pfizer's RSV PreF vaccine is the surface F protein. The F protein is anchored on the surface of the virus. It undergoes a change from its metastable prefusion conformation on the left to a stable post-fusion conformation as shown on the right, causing it to fuse with the host cell membrane and facilitate cell entry. The Pfizer vaccine targets the prefusion form to induce antibodies that are most effective at blocking viral infection. This is an overview of the maternal clinical program, starting with a large non-pregnant study and progressing to safety and efficacy studies in pregnant women. Today, I'll focus on our 2 maternal studies, including a phase 2b SAVI study, a dose finding and immunogenicity study, and our phase 3 efficacy study. Both studies were conducted in pregnant women who were between 24 and 36 weeks gestation at the time of vaccination. The phase 2b study was a proof of concept study, and shown here are immunogenicity results in a subset of participants who received the 120 microgram dose from a total of 562 enrolled maternal participants following vaccination. Gray is placebo, and blue is the RSV PreF vaccinated maternal groups. As you can see, the neutralizing geometric mean titers are robust at 1 month after vaccination and remain high not only at delivery, but at 6 months postpartum. The RSV PreF antibodies were found to be efficiently transferred to the infant, as shown here by the neutralizing titer transfer ratio, looking at maternal serology at delivery and contemporaneous infant cord blood samples in an infant to maternal ratio. At the 120 microgram unadjuvanted selected dose, transplacental transfer ratios were over 1 overall in dark blue, and high by geography in light blue, and high in each maternal gestational age category at vaccination in green. Following on the transplacental transfer data, this slide shows the kinetics of the antibody responses in infant participants at birth, 1, 2, 4, and 6 months after birth, showing the geometric mean neutralizing titers. The RSV PreF group in blue remains higher than placebo and gray at all time points. Although there is no correlative protection, a reference titer of 100 mics per ml of palivizumab is shown in red for demonstration purposes. I'll now present efficacy from our phase 3, data from our phase 3 efficacy study, Matisse. So Matisse, or the Maternal Immunization Study for Safety and Efficacy, was conducted in 18 countries globally, including all 3 of the North American countries, 3 in South America, 4 in Europe, 2 in Africa, and 6 in the Asia Pacific region. Women were enrolled if they met qualifying criteria and were less than 50 years of age and between 24 and 36 weeks at the time of enrollment. Over 7,000 vaccinated mothers and their infants are included in this analysis. The study began in June of 2020, and follow-up of the cohort is ongoing until the last infant completes the study in Q4 of 2023. This study covered 4 seasons, 2 in the southern, 2 in the northern hemisphere, and women were randomized 1-to-1 with either the study vaccine or placebo. The participants randomized to the RSV PreF group received a single dose of the 120 microgram bivalent vaccine, which contains equal amounts of each prefusion F antigen from RSV subgroups A and B. The vaccine does not contain any adjuvant. This is the maternal schedule of study activities used in the clinical trial. Maternal participants were screened, including with an ultrasound if it had not already been performed as standard of care prior to vaccination. Safety was monitored with a self-reported eDiary mobile device soliciting adverse events for 7 days following vaccination. All adverse events were collected for a month, and delivery as a variable time period may have occurred at any time after vaccination, and in most participants, delivery occurred outside of the adverse event 1 month period. Therefore, we collected adverse events of special interest, AESIs, including preterm delivery, and serious adverse events throughout the study period. In these maternal participants, surveillance for respiratory tract illnesses was conducted through chart reviews, but swabs were not taken. For the infants born to those vaccinated mothers, adverse events were collected from their first live breath to 1 month after birth. Adverse events of special interest, the AESIs, serious adverse events, and newly diagnosed chronic medical conditions were collected throughout the study period. The infants enrolled in the first year of the study were followed for 2 years. This was approximately half the infants. The remaining infants were enrolled for a year. Respiratory tract illness surveillance was conducted throughout the study period, with swabs being performed for all medically attended respiratory events in the first 6 months, and for hospitalization and severe illness respiratory events throughout the study period. All cases were adjudicated by an independent event adjudication committee. Shown here are the maternal demographics. The maternal characteristics reflect the diverse study population and were similar between the RSV PreF on the left and placebo groups. The average age of vaccination for our maternal participants was 29 years, with participants ranging from 14 to 47 years overall. As you can see, data was generated in adolescent participants, and we will propose to include them in the indication. The average gestational age of vaccination was 30 weeks, with a substantial number of participants vaccinated early in the qualifying 24 to 36-week gestational window. For the infant participants, they also represented a diverse population, and there were approximately equal male and female participants. Demographics were similar between, again, the RSV PreF group on the left and placebo groups. The study objectives for the trial are listed here, including safety in the maternal and infant populations and efficacy endpoints in the infant participants. There were 2 equal primary endpoints of medically attended lower and severe medically attended lower respiratory tract illness through 6 months of age. For the review of the safety data, I'll first start with the maternal participants and with reactogenicity that was solicited in those vaccinated women in their e-diaries. These graphs represent the solicited local reactions. They were mostly mild in green or moderate in blue and higher in the vaccinated group. The most commonly reported local reaction was injection site pain. The solicited e-diary systemic events by maximum severity, again for maternal participants following vaccination, are shown in these graphs. The events were mostly mild in green or moderate in blue. Few fevers were reported overall and were similar between the vaccine and placebo group. The most commonly reported event, fatigue, was similar between the vaccine and placebo groups. Headache incidence was slightly higher in the RSV PreF group compared to the placebo group, and muscle pain was reported more frequently in the RSV PreF group compared to the placebo group. This slide reviews all adverse events by type in the maternal participants within 1 month after vaccination. Overall, adverse events were common. This was expected from known background rates, as this is a maternal study that includes a delivery period. In each category, the events are similar between the RSV PreF in blue and placebo group in gray, including the category of serious adverse events. There are 5 related serious adverse events reported in the study to date. All are in maternal participants. There were 4 related serious adverse events in the RSV PreF group and 1 in the placebo group, and all of the events are reported as being resolved. This is a similar layout, and this slide reviews all adverse events by type in the infant participants. The rates of adverse events overall in the first month after birth were higher in the maternal participants. This too was expected from known background rates for a study covering the neonatal period. The events were similar, with no statistically significant differences seen between the RSV PreF and placebo groups in all categories shown, including adverse events of special interest or AESIs and in congenital anomalies. This slide focuses on adverse events of special interest that I have been referencing before, including terms of prematurity, low birth weight, and events of developmental delay. These were collected throughout the study period and were similar in the RSV PreF group in blue and placebo group in gray. Global estimates put infant prematurity at approximately 10% of all births. The rate of prematurity in the study was low at a little over 5% for all infant participants. This likely reflects the maternal eligibility criteria in the study, including the inclusion of singleton pregnancies only. This slide summarizes all the deaths and fetal losses reported in the trial. All events summarized in this slide were deemed unrelated by the investigator and sponsor. This data, along with safety information in the ongoing study, is reviewed by an external data monitoring committee, and the external adjudication committee reviews all deaths related to respiratory illnesses of any etiology. Maternal deaths were rare. There was a single maternal death which occurred in a woman in the Philippines who had an unexpected home birth and died of hypovolemic shock secondary to postpartum hemorrhage approximately 2 months after vaccination. The majority of pregnancies in RSV PreF vaccinated mothers resulted in live births. Stillbirths and fetal deaths were rare and reported in no more than 0.3% of participants in each group, or 10 in the RSV PreF and 8 in the placebo group. The incidence rate of fetal demises in maternal participants who received RSV PreF was lower than estimated background rates globally and by country. There were 17 deaths overall at the time of the analysis, 5 in infants born to RSV PreF vaccinated mothers, and 12 in infants born to placebo recipients. There is only 1 infant associated with RSV, and that event was in an infant from Japan and in the placebo group. I'm now going to review the efficacy data in this pivotal phase 3 study. These are based on an interim analysis conducted in October of 2022, which was successful and resulted in a final analysis of all the infant efficacy data. Infant participants were followed regularly by a weekly e-diary responses or phone contacts to determine if they had ever sought care in that past week for a respiratory tract illness. Each time they did, a study swab was taken for RSV, and vital signs were systematically collected by the study sites. Any data collected from the study sites, the physician, a hospital visit, it was all collated for a combined review of data by an independent adjudication committee to determine if it was a case. All cases had to have a valid molecular swab, positive for RSV, and case definitions used by the adjudication committee are listed here for the 2 endpoints of medically attended RSV, lower respiratory tract illness, and medically attended severe RSV, lower respiratory tract illness. Based on the successful interim efficacy analysis at 90 days, the full analysis of infant efficacy endpoints was conducted on the infant evaluable efficacy population and is shown here. The efficacy for 2 equal primary endpoints of severe medically attended lower respiratory tract illness above and lower respiratory tract illness below are represented. For severe medically attended lower respiratory tract illness, the statistical criterion for success with a lower bound of 20% was met with 39 cases within 90 days after birth and a vaccine efficacy of 81.8%. and was similarly met with 69.4% efficacy at 180 days with 81 total cases. Cases are cumulative at each time point, and case splits are shown. For medically attended lower respiratory tract illness in the below graph, the interim analysis results based on 80 cases at 90 days did not meet the statistical criterion for success with the lower bound of 20%, because that interim analysis required the use of the very stringent 99.5% confidence level. It's notable that the confidence interval for vaccine efficacy at later time points analyzed after the successful interim analysis all have a lower bound greater than 20%, with point estimates comparable to the 90-day result. Medically attended lower respiratory tract illness to 180 days included 174 total cumulative cases of RSV positive events, with the case splits as shown and an observed vaccine efficacy of 51.3%. This is the secondary endpoint showing the efficacy of RSV positive medically attended lower respiratory tract illnesses that I showed in the prior slide, but this one is within 360 days after birth. With 248 reported cases through a year, the cumulative vaccine efficacy met the statistical criterion for success, or a confidence interval lower bound more than 0% at all time points, corresponding to an observed vaccine efficacy between 40 and 45% over the period of months to a year. This is the results from our secondary endpoint showing the efficacy of RSV positive hospitalizations within 360 days after birth. This definition included all infants that had confirmed RSV that resulted in an admission to a hospital. Although severity criteria were not applied, more than half of these cases also meet the criteria for severe medically attended lower respiratory tract illness. With 63 cases of hospitalization with confirmed RSV, vaccine efficacy was met for the predefined criterion within 180 days. I'm now sharing data on an exploratory endpoint of RSV positive medically attended RTI, or respiratory tract illnesses, as confirmed by the Endpoint Adjudication Committee. There were no pre-specified criteria for success on our exploratory endpoints, so a 95% confidence interval is shown for presentation purposes. This endpoint looked at all RSV positive medically attended infants who had respiratory tract illness symptoms. In short, an infant went to the physician or sought healthcare, and they were confirmed to have a valid RSV test within 6 months of birth. Similar to the hospitalization endpoint, severity criteria was not applied. Vaccine efficacy was approximately 38 to 39% through the 6-month period, with confidence intervals above 0 for all time points, showing that vaccine efficacy was demonstrated across the spectrum of RSV disease, even down to milder presentations of the disease as shown here. This slide reviews the efficacy for severe and medically attended lower respiratory tract illness by RSV subgroup A or B. For demonstration purposes, again, a 95% confidence interval is shown to evaluate the efficacy of A and B, as there's no pre-specified lower bound criterion for an exploratory endpoint. Nonetheless, efficacy for RSV A and B is largely consistent with the overall analysis. Note that for RSV A, there were lower cases overall. And actually, interestingly, this was seen in each year of the study and in each season. And this results in overlapping but wider confidence intervals as seen. In summary, the phase 3 trial demonstrated that the RSV PreF investigational vaccine was well tolerated with a favorable benefit-risk profile. The totality of the data demonstrates that efficacy in infants born to mothers vaccinated in 24 to 36 weeks was met for the severe medically attended lower respiratory tract illness endpoint through 6 months, and clinically meaningful efficacy was observed for the medically attended lower respiratory tract illness endpoint through 6 months. And when combined with the secondary endpoint, efficacy was demonstrated through a year. Our thanks go out to all those who participated in the study and allow me to contribute and present this data to you today. And I'd be happy to take any questions from the committee.
Thank you very much for that presentation. It's now open for questions, and Dr. Talbot has her hand raised.
I have two. Right quick, for the slide 8, which you showed the duration of the antibody response in the infants, were you able to differentiate what impact breastfeeding had on that?
Thank you, Dr. Talbot. So I hope that you're meaning this kinetic slide. So this is from our study. We did not test breast milk usage in the study. We do collect data on whether or not maternal participants were breastfeeding. In the phase 2b study, our ex-US cohort was low, and what we have found in the phase 3 study is that actually the ex-US cohort more consistently drives the frequent breastfeeders. So that was not analyzed in the phase 2b study, in part because of low numbers.
Okay, that's fascinating. And then the second question is, have you looked yet at co-administration with influenza vaccine?
Yeah, thank you for the question. So we do have 2 published trials that we conducted, as I showed you the clinical development plan overall, we conducted a study characterizing co-administration with influenza in non-pregnant patients, and then did actually a non-inferiority study looking at Tdap co-administration in women. So regarding influenza co-administration, it was descriptive, not a non-inferiority study. But in the non-pregnant participants in the lower age groups, there was a trend towards lower titers to influenza overall. And so we did not recommend co-administration in the phase 3 study. There is this same vaccine, the 120 microgram RSV PreF vaccine, is actually being studied in an older adult population, as you well know. And there is a study ongoing that is assessing non-inferiority of co-administration in that older adult population. But for the maternal population, there would be no additional clinical studies, and we would actually analyze that in a larger post-marketing cohort.
Dr. Paling?
I want to say thank you for this presentation. I've got 2 questions. One is a safety question. And do you have data on congenital malformations in the both the placebo and the control group? If you do, I'd love to see that.
Yeah, thank you very much. So in all of our clinical studies, congenital anomalies are collected as serious adverse events for complete reporting. So they're collected throughout the study period. For congenital anomalies, in order to have the most complete and consistent reporting, we actually requested that the investigators follow guidance by the CDC's Metropolitan Atlanta Congenital Defects Program. So they were given a systematic list to report those congenital anomalies. They were collected through the study, and you see the rates of congenital anomalies presented here by adverse event comparison types. With 5.9 in the placebo and 4.8 in the RSV PreF group, there was no difference between the 2 groups.
And can you remind me the background rate in this population?
Yeah, it's a complicated question because there is variable reporting on congenital anomalies. So WHO rates versus US rates. So we had anticipated a similar background rate, but that was based on comparable maternal studies, not actually based on other studies of background rates, because this population is quite unique in that it sort of self-selects for reasonably women who have had screening ultrasounds, right? So our women are not all comers in the study. If there is any congenital defect on their screening ultrasound, which is mandatory, they're actually excluded. Okay. So rates would be higher in a maternal population. And so we had compared ours to other maternal programs of which were comparable.
Okay, and thank you for that clarification. That's very helpful. My other question is very similar to Dr. Talbot's, and the question is, in the phase 3 trial, have you done a sub-analysis where you look at breastfeeding and non-breastfed and look at the efficacy of the vaccine? Thank you.
Yes. So that's one of the things that we're continuing to pursue. Again, we collected data from the participants about whether or not they were breastfeeding, whether or not it was exclusive, and the duration of breastfeeding. So that is data that we look to analyze, but we do not have data on actual breast milk composition or antibodies in breast milk in either of the studies.
Thank you. Dr. Daly?
Yeah, thanks so much. If you could go to the slide that has 360-day efficacy. And my question is, this is just a gestalt, but I guess I was a little bit surprised that efficacy declined a fair bit by 360 days, because I would have thought that once you got through the season, you would then be, there wouldn't be very much RSV disease happening after 180 days. So I wonder if you've looked at this as a time to event and whether you've looked at it stratified by the time of year that a woman was vaccinated. Thank you.
Yeah, so I'll just reemphasize the study period that we conducted the trial in, because this may give you a little bit of context. So the study started in June of 2020, and we conducted the analysis in October of last year. So we undertook the study during a variable RSV seasonality period. And so some of the infants were exposed during their first 6 months, some of the infants were exposed after their first 6 months, and some of the infants were exposed at both time points, we think, based on background epidemiology that we were collecting from the sites at the time contemporaneously. So what we see here may or may not be predictive of what you would see in a sort of typical peaked RSV season. I'd also reflect on the fact that we continued to collect all the hospitalization and severe swabs throughout the study, but after 6 months, we did not systematically collect lower respiratory tract illness. So there's the consistent swabs were done for hospitalization and severe.
Thank you, Dr. Sanchez, and then Dr. Lehrer. So we'll go to Dr. Sanchez first.
Thank you for that presentation. Certainly exciting to potentially have a maternal vaccine. A couple questions. First of all, how many, in terms of adverse effects, how many overall had severe temperature elevations to 39 to 40. It's just a small little bar there. And first of all, and second of all, how was developmental delay defined? Did they have formal developmental assessments? I know there's very few of them. And among the women who had elevated temperatures in the severe range, were those outcomes, those infant outcomes were okay, or was that the ones who had developmental delay? And then how many of these women actually had RSV infection? I don't know if you mentioned that, I may have missed it. But did you evaluate the maternal efficacy? And if any woman did have RSV, how did that contribute to her own antibodies and the transplacental passage?
Thank you very much for the question. So I'm going to try to go through them. Please catch me if I don't get to everything that you wanted answered. So this is the fevers for the RSV PreF and the placebo group. So if you look at the 39 to 40 group, there were 6 fevers. 1 was in RSV PreF and 5 were in placebo. If you look at the fevers over 40 degrees, there were 8 reported. 3 were in RSV PreF and 5 were in placebo. Regarding developmental delay, when we looked back, we did not see consistent trends. I cannot speak to whether or not we specifically looked at fever, so I'll have to get back to you on that. But we looked through all of those cases and did not see a consistent trend in any maternal reactogenicity, maternal adverse events, maternal history. Largely, those events of developmental delay are actually occurring in months or maybe even over a year, because some of the events that you may be thinking about as birth defects would actually fall under the criteria of congenital anomalies. Regarding developmental delay, we took guidance from Gaia and also the reflection on that it should be the highest order provider giving that diagnosis. So the developmental delay is a big umbrella term, but what we did ask was that a pediatrician and if possible, a developmental pediatrician evaluated the child. So all our study sites had to have a PI or a sub-I who were experienced in pediatrics and in the evaluation of pediatric developmental delay. And so it was the highest order provider diagnosis. And then regarding the maternal RSV, there were scant women in the study who had any RSV. We did not systematically collect those swabs. So it was really maternal reported events and whether or not any local testing was done. So we really didn't see any number of RSV cases in our study. And there was no difference in the maternal respiratory tract illness events overall or by any given pathogen type.
Thank you. Okay, we're going to go to Dr. Paling.
Thank you. Could you remind us what the placebo was? Thank you.
Yeah, so it's a lyophilized powder, and we mix it with water for injection. And so the placebo is just the excipients. It's the 2 antigens removed. So it's a matched placebo. So when they mix it with the water for injection, it looks identical to the vaccine. So it's the water for injection plus the excipient lyophilized vial.
Thank you. Dr. Long?
Yes, maybe you said this and I missed it, but in reference to the antibody decay slide in the placebo and intervention group in the infants over the first 6 months, the question is, did you do this study outside of the RSV season only, or did you did you have the blood to know somebody got RSV and remove that person? I would have thought there would have been RSV occurring in both groups, but especially in the placebo group.
Yeah, so thank you for the question. So this study was actually conducted in 2019, in a very typical RSV season. So we did have infants who were exposed to RSV during this time period, and we would be able to get that data and share it. I don't have that data with you to share with you those exact numbers today, but we would be able to get data to show you the difference in these participants versus the participants who tested positive and or had antibody evidence of exposure to RSV.
So I understand what is on this slide could include many infants who had RSV.
It includes some infants who had RSV, correct? Yes. The efficacy in this phase 2b study in a small number of 8 participants was also shown. So there is obviously the confounding factor that in the RSV PreF group, we saw fewer cases.
One last question for me. This is Grace Lee. If you could just, and I might have missed it, but did you look at maternal pregnancy outcomes as well? And I'm thinking about preeclampsia, preterm labor. And then my other question relating to preterm delivery is what proportion of kids were born at what gestational age? And I'm just thinking about placental transfer of antibody, and if you had if you have enough moms who delivered prematurely, where it'd be worth stratifying to take a look at the level of protection.
Yeah, thank you very much for the question. So regarding maternal outcomes, yes. So we looked at all adverse events within the first month. And as I said, because delivery occurred outside of that period, we looked at specific maternal factors, including the mode of delivery, whether or not that delivery was successful, whether or not it was preterm, and then obviously collected any serious adverse events throughout the study. All of those different groups that I'm explaining to now were similar between the RSV PreF and the placebo group, and we can get you more granular data on any given SOC, a system organ class or preferred term. By and large, when you see that any adverse event category there, even though this is the first month, overall in our study, the main driving adverse events are pregnancy-related events. They by far and away outweigh all of the other terms. For example, premature delivery, preeclampsia, and gestational hypertension were the top 3 terms reported in our study. So we do have systematic data on all those types of terms. And as I said, there was no difference in those 3 that I mentioned in other maternal adverse events.
Yeah, That would be great just to have that granular data at some point, because I do think those are common things we look for in most of our vaccine safety surveillance systems with regard to pregnant women or pregnant people.
Yeah, absolutely. And we can certainly send both for our adverse events and our serious adverse events, particularly in the pregnancy category. And then regarding your question about antibodies and term, preterm, these trials, what we have found, and this is not only us, it does tend to self-select out a slightly more healthy population who's lower risk of prematurity. Our intent was to enroll a diverse population. We allowed, for example, controlled diabetes or controlled hypertension. But despite that, with particularly singleton pregnancies, we did not see a high rate of preterm in our study. What we can look at, and this is data from the phase 2b, study, is the antibody responses in women who got vaccinated early in that period to late in that period. So looking at the maternal gestational age of vaccination, but with really about 5% preterms, we have very few. In the phase 3 study, that number, the percent is low, but that number is higher, but we have not yet analyzed the serology data. The last births did come in after the interim analysis, and so we are looking to analyze the serology data going forward, particularly in the preterm infants is certainly of interest to us as well.
Thank you. Dr. Sanchez?
Thank you. Well, along with that, I was wondering if among the infants who developed RSV infection, particularly in the women who had been vaccinated with the pre-fusion vaccine, have you been able to, or are you planning to measure neutralizing antibodies to see if your surrogate marker of protection, which looks like it's from palivizumab, if that holds up? Are those infants who had lower levels versus, I mean, is there any, if you're able to get any correlate? And then along with that, among those infants who did develop RSV infection, were they more likely to have any comorbidities such as prematurity? And if they did receive palivizumab because they were preterm, were those excluded from further analyses?
Yes, thank you for the questions, and I will try and touch on each of them. So for the infants that got RSV and their antibody responses, as I said, the last growths came in after the study, so that the immunogenicity has not yet been collected for the phase 3 study. So we do not have immunogenicity at this time to match with the efficacy data that I'm showing. So the immunogenicity data that I was showing you was from the phase 2b study. Pfizer does have plans to look at different immunogenicity outcomes for that data in the coming year. For the infants who got RSV, were they more preterm? Were they more comorbid? No, that doesn't appear to be the case. So we there are small numbers when you look at them going through, but case by case, we don't see that. And we don't actually see when you get these breakthrough infections, they're not getting worse disease, enhanced disease. They're getting disease that you would typically see in RSV infants or milder. Regarding your question about palivizumab, palivizumab was permissible in the study as recommended by each country or region. We were 30% in LMICs, whereas palivizumab is not frequently given. So we relied on the local geography and practices to administer palivizumab. Only a dozen babies in our study received palivizumab, and there were no cases in those infants, so we couldn't analyze efficacy by co-administration of palivizumab.
Thank you. And the last question goes to Ms. Hayes, and then we're calling it a wrap until the next session. Ms. Hayes?
Sorry, I'm rattling away with mute on. Carol Hayes with the American College of Nurse Midwives. I want to thank you for this study. I think you did a great job on your racial and ethnic diversity. And I want to also thank the committee for your excellent questions related to pregnancy complications and newborn complications. And I look forward to more data on this. Thank you.
Thank you very much. And thank you for your presentation. And with that, we'll move to Dr. Fleming-Dutra to hopefully provide the workgroup considerations and wrap this up.
Yes, and I'll be brief. And can you bring up my slides? Great. So I'll present the workgroup considerations regarding maternal RSV vaccine. And next slide.
The policy question being considered by the work group is, should the Pfizer RSV bivalent pre-fusion F vaccine be recommended for all pregnant people as a single dose given at 24 through 36 weeks gestation? This maternal vaccine is targeted at prevention of RSV disease in infants, and therefore, should this vaccine be licensed by FDA, this recommendation would be considered in the context of the current standard of care for prevention of RSV disease in infants at the time of an ACIP vote. Next slide. I would like to highlight a few considerations regarding this vaccine, including what the data from the trial can tell us regarding the timing of dose within pregnancy. First, as stated by the manufacturer, the dosing window in the trial was 24 through 36 weeks gestation, and currently there are no data available on efficacy stratified by gestational age at time of administration. It's important to note the majority of infants in the phase 3 trial were born at term, meaning 37 weeks gestation or later, and the most doses in the phase 3 trial were given at 28 weeks gestation or later, as shown here. And this means that the efficacy data from the phase 3 trial largely reflect doses given in the third trimester and babies born at term, and data regarding efficacy in infants born preterm are limited. Next slide. Additionally, regarding the number of total lifetime doses, all pregnant people in the trial received their first and only dose of RSV vaccine, and currently there are no data available on the efficacy of the first lifetime dose during subsequent pregnancies or the safety of additional doses given in subsequent pregnancies. Next slide. And to wrap up, here's the proposed tentative timeline of future ACIP presentations regarding this vaccine. At the June 2023 ACIP meeting, we plan to present a summary of grade of the evidence, a cost-effectiveness analysis, and the evidence to recommendations, or ETR framework. And then an ACIP vote could be held in October 2023 if the product is licensed by this time. Next slide, and thank you.
Thank you. Would anyone like to ask any questions? Dr. Talbot.
I would love, before we make this decision, to have information on co-administration of flu and RSV. And also, it's probably going to be flu, RSV, and COVID. So I think we need to have those studies and need to have antibody levels prior to making a decision. Oh, sorry, NTDAP. I like my viruses.
The other consideration, and I apologize, this adds complexity, and I recognize you wanted to sequence it, but I could imagine a combined platform where we protect infants against RSV, and so just thinking through how to integrate this, if we discuss nirsevimab first, and then this vaccine second, sort of when that comes through, if and when that comes through, how should we think about it from a decision-making perspective and thinking about the relative benefits and risks? And I can imagine, for example, there may be women who deliver quite early and never have an opportunity to get a vaccine. Sorry, a pregnant person who delivers early who might not have the opportunity to get a vaccine, and that might be where it would be really useful to have monoclonal antibody available. So just, thinking through those scenarios would be really helpful, although I recognize that's really complex. Dr. Daly.
Well, and related to that, just understanding biologically the implications of maternal vaccination followed by passive immunization in the infant. I mean, I think there's biologic reasons to suspect that it's not problematic from a safety standpoint and would probably be additive from a effectiveness standpoint, but I want to make sure I'm not making too many assumptions.
Well, and then the cost effectiveness, just to throw that on top, because that's, we're already discussing that. Ms. McNally.
I'm just wondering where the work group is contemplating that the pregnant woman would receive the vaccine. When women were beginning to receive more Tdap, a lot of offices were not stocking it. So I'm just curious about that. Thank you.
I mean, it's a good question. I think many Tdap in particular is often administered in obstetrical practices or wherever the pregnant person receives their obstetrical care, but certainly something we'll continue to explore and discuss with our implementation colleagues.
Dr. Paling.
I wanted to emphasize the point about how do we pull these together, because not only do people deliver too early, but I'm also really worried about the we see a fair number of persons that deliver that had no or very scant prenatal care. And those infants tend to have a lot of risk for hospitalization. So how do we address that? And then that gets to our equity issues as well. Thank you.
And actually, I'd be curious to know how pregnant people feel about acceptability, values and preferences with regard to would you rather receive a vaccine during pregnancy, or would you rather your infant consider getting nirsevimab, for example? I don't know if people have different preferences.
Yes, thank you for that question. So as part of the survey that Dr. Jones already presented regarding nirsevimab, that particular survey also asked questions about maternal vaccination. We were planning to present those data as part of ETR, but we're certainly happy. That survey asked both about antibody and maternal vaccine, so we can bring those data back to ACIP.
Thank you. Are there any objections to taking a break? Okay, we are going to take a 15-minute break, and thank you so much to the presenters of that last session, because it was an incredible amount of information and really important. Thank you.